الرحمن الرحيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. يسرني ويسعدني في هذا اليوم 8 من شهر ربيع الثاني 1443 الموافق ل13 من نوفمبر 2021 أن أفتتح الندوة التي يقيمها المركز التدريب والتعليم جمعية شفاء بمناسبة اليوم العالمي للسكري، وهي بفضل الله أول ندوة ينظمها هذا المركز الذي تم الحمد لله الاعتراف به من هيئة التخصصات الصحية كمركز للتدريب والتعليم في جمعية شفاء، فنحمد الله على ذلك ونسأله أن تكون بداية موفقة بعونه وتوفيقه. هذه الندوة تقام بمناسبة اليوم العالمي للسكري، وهي مناسبة دولية يحتفل بها الاتحاد الدولي للسكري كل عام في جميع المناطق العالم، توعية المجتمع أولا والمصابين ثانيا والمخططين للصحة بشكل عام ثالثا. لا يفوتني أن أشكر كل من ساهم معنا في هذه الندوة من الإخوة الأطباء الاستشاريين الذين تم اختيارهم بناء على خبرتهم الواسعة في هذا المجال. ولا يفوتني أيضا أن أتقدم بالشكر للجنة المنظمة التي عملت على تنظيم هذا المؤتمر، وأيضا لا يفوتني أن أشكر كل الحاضرين معنا الذين شاركوا، ولا شك أن في هذا دعم أولا للعمل الخيري، وثانيا دعم للنشاط التعليمي، ودعم أيضا لجمعية شفاء. فأشكركم جميعا، وأسأل الله سبحانه وتعالى أن يوفقنا في هذا اليوم لتقديم ما هو مفيد لكم. ختاما، وكما تعلمون أن كل بداية لا بد أن يكون فيها ملاحظات، فأرجو أن لا تبخلوا علينا بإرسال ملاحظاتكم وآرائكم لتطوير مركز تدريب التعليم في جمعية شفاء. وأيضا لا يفوتني أن ندعوكم جميعا للمشاركة بخبراتكم في هذا المركز. أشكركم، وأترك الآن الميكروفون لسعادة الدكتور فيصل مالكي رئيس الجلسة الأولى لنفتتح هذا المؤتمر. والسلام عليكم ورحمة الله.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. First of all, I'd like to thank you, all of you, for joining us today in this World Diabetes Day Symposium. Special thanks to Dr. Khalid Tayyib, Chairman of Shifa Charity Society, for kind invitation and nice organization. It's my pleasure to participate and introduce now the first speaker in first session, Dr. Khalid Tayyib. He is internal medicine consultant and endocrinologist, and he is the chairman of Shifa Charity Society. Dr. Khalid Tayyib will talk about epidemiology of type 2 diabetes. Here you are, Dr. Khalid. Welcome.
I'm sorry, as we said, always at the beginning when there's problems. So we have diabetes, we have impaired glucose tolerance, we have an impaired fasting glucose. Now, to diagnose diabetes, you can have one of these 4 categories. Either you have a fasting of more than 126 milligram per deciliter. That is enough. If you have 2 times fasting blood glucose of 426, and this is enough to diagnose diabetes. Or if you have a 2-hour blood glucose more than 200 milligram per deciliter, again, you can diagnose diabetes. Or you get an A1C, which is equivalent or more than 6.5%. Or if you get a random blood glucose of more than 200, then the diagnosis of diabetes can be made. So you have 2 or 4 options to diagnose diabetes, and one of them is enough. So you get a fasting more than 26, postprandial more than 200, or a random blood glucose more than 200, or an A1C of more than equivalent or more than 6 points. Now, impaired fasting glucose, you need to have a blood glucose less than 126, that is less than the diagnostic criteria for diabetes, and you have to have a random 2-hour blood glucose between 140 and 200. So you need both to diagnose impaired glucose tolerance. You need both fasting, which is less than 126, of course, more than 100 and less than 126, and postprandial less than 200 and more than 140. Now, the third category is an impaired fasting glucose. Now, impaired fasting glucose, you can diagnose if your fasting blood glucose is between 110, 125 milligram per deciliter. And of course, if you measure random blood glucose, you find it 140 or less. Okay, so to diagnose diabetes, you need one of these 4 categories. Diagnose impaired glucose, you need 2 categories, such as blood glucose less than 106 and a postprandial less than 100. And to diagnose impaired fasting glucose, you have to have high, above normal fasting glucose and a normal postprandial blood glucose. So how about diagnosing gestational diabetes? We get a lot of criteria to diagnose gestational diabetes, and one of them is the ADA, ACGO, ACOG, which is American College of Diabetology and the American Diabetes Association. These put a fasting blood glucose of 95, 1 hour of 180, and a 2 hour of 155, and a 3 hour 140. This is the criteria, and this is the most common maybe criteria. It was put in 2003 and began to emphasize in 2018. Now, if you look at the ASD criteria, it's a little bit different. We have the fasting blood glucose more than 110, and 1 hour, it's not there, but a 2 hour of 162 is enough to diagnose patient diabetes. Similarly, the WHO has got also a similar criteria for that. So we have different criteria to diagnose gestational diabetes. Now, other specific types of diabetes also exist, and these include diabetes that is caused by disease of the exocrine pancreas. This pancreatitis, a trauma, infection, pancreatic cancer and pancreatectomy. And of course, we get diabetes due to endocrine disorders that causes excess secretion of hormones that antagonizes insulin, like cortisol, for instance, like Cushing's syndrome. And you've got drugs and chemical-induced diabetes from drugs that disturb insulin secretion or insulin action. And this we call other specific types of diabetes, which also include infection-related diabetes that is caused by viral infection to do with beta cell destruction, uncommon specific immune-mediated diabetes, like in type 1 diabetes, immune type 1 diabetes. Other genetic disorders can also be a cause of diabetes. Now, let's go to the data from the International Diabetes Federation, and this is the up to date. This is the data that we have from the International Diabetes Federation. So if we look at the world as a whole, we got a total population now in 2019 of 7.7 billion and an adult population of 5 billion. The global prevalence of diabetes in 2019 was 9.3%. The number of people with diabetes was 436 million, and the number of deaths due to diabetes was 4.2 million. Now, these figures are all are expected to rise in 2030 and 2045. So diabetes globally will be increasing in prevalence. We'll have more people to be affected with diabetes. And that, of course, will increase the total health expenditure for diabetes, which was actually in about $760 billion, not a million, billion dollars in 2019. And of course, will also rise to 845 billions in the coming 2 decades. Hypoglycemia in pregnancy in ladies between 20 and 49 years. The proportion of live birth affected is about 15%. The number of live birth affected about 20 million, or was 20 million in 2019. Impaired glucose tolerance, a global prevalence of 7.5. So if you add this 7.5 to the 9.3 global prevalence of diabetes, you will have almost about 19% total population in the world either are diabetic or have impaired glucose tolerance. And that, of course, gives you an idea about the high prevalence of the disease. Now, the number of people with impaired glucose tolerance was 373 million. Type 1 diabetes, the number of adolescents with type 1 diabetes in 2019 was 1,110,000. The new cases was 128,000 cases per year. 2000. Of course, we don't know the figures. Type 1 diabetes. Now, as you know, diabetes is more common in elderly people. So if you got look at different age groups, starting from 20 to 40, ending 20 to 24, ending to 75 to 79, you can realize definitely that the older you are, the more likely to develop diabetes. And this is going in all age groups. Actually, only after 65 years, the data is almost about similar. But once you are 40 plus, then the prevalence of diabetes is more, and people are more likely to get diabetes in their past. And this means that if we want to do a surveillance for diabetes, should go maybe from the age of 35 here. Okay, and this is another slide that shows you the global estimates in people older than 65 years in 2019 and 2030, 45. And you can see that the adult population will be increasing in the next decade. The prevalence of diabetes in people of 65 years is currently around 20%, but also be going higher in the next 2 decades. The number of people older than 65 years with diabetes will be 135 million, going to 195 million, and maybe more than 270 million in the next 2 decades. So we are getting more elderly population, and we will be getting, therefore, more people affected with diabetes. So, and if you see the aging problems at different regions of the world, you find that the people in the North America, in elderly people more than 65 years, the prevalence of diabetes is 27%, while our region, the MENA region, it is 24%, followed by South and Central America by 22%. It's less in Europe and less in Western Pacific, Southeast Asia, and Africa. So really, we have to look at this. Diabetes is a problem of older age groups. So the elderly have to be looked at for diabetes. Now, this is the global, sorry, this is, we should go further. This is the top 10 countries for the number of people older than 65 years. So we said that in Central America and in the United States, in prevalence, we have higher prevalence in high age groups. But if you go to the number of people with diabetes was more than 65 years, then China goes at the top, followed by United States of America, India, Germany, and so on. And here we have 35 million people, and we have only 14. Of course, China has a much higher population number than America. Now, if we look to the sex difference in the prevalence of diabetes, we find that men, unfortunately, has got a higher prevalence than women in the prevalence of diabetes. We had 240 million men and 220 million women. But again, this will continue in the next 2 decades. So men are more likely to be affected. However, there are a lot of data. This is if you look at it globally. But if you look at it maybe in different regions or different countries, maybe you'll find that some countries or some regions, women are more affected by diabetes than men. So, but if you go look at it globally, then men, of course, are more affected. Now, this is interesting. Here we are looking at the prevalence of diabetes in urban and rural areas. Now, if you look here, you find that by time, in the next 10 to 20 years, the global prevalence of diabetes in urban areas is rising. Okay, this is millions. So this is 300 million, will be 400, and will be more than 500. But if you look at rural areas, you find that we have a similar number of people in rural areas. Now, this is if you look at it globally, and why is this? Why there is an increase in the urban and no increase or no much of increase in the rural, because they say that by time more people are moving from the rural areas to the urban areas. So with more civilization, you would expect that more people are moving from the rural areas and going to the urban areas. However, I can tell you, I have seen a lot of studies that have looked at this, and there was similar prevalence of diabetes between rural and urban areas, or almost similar. But if you look at it globally, then urban areas is more affected. People in urban areas are more affected by diabetes than rural areas. This is adults 20 to 70 years with undiagnosed diabetes. So this is another issue, that we might have people who are undiagnosed. This is one of the unfortunate issues in diabetes care, that we get a lot, almost 50% of all people affected with diabetes, almost 50% are diagnosed. And this is more of a problem in Africa and Southeast Asia. And in our region, in the MENA region, we get 44.7% of people affected by diabetes are undiagnosed. Of course, this will tell us how much we need to do screening for diabetes, especially elderly. So this is a real problem in diabetes care, undiagnosed diabetes. We have always to remember this. Now, if we go to children, and we estimate the number of children, adolescents, 0 to 14 years, who is prevalent existing type 1 diabetes, that means they already have type diabetes, you can see that Europe has got more than 160,000 child with diabetes. In our region, we have almost half of this. So 160 in Europe. MENA region is only 80,000. North America is more, maybe 120. Similarly, Southeast Asia, 100. And the least, of course, is in Africa. So type 1 diabetes, as we can see from this, is more prevalent in Europe, especially in the Scandinavian areas. But of course, we are also picking up in our region. So, and this is the estimated annual incidence, yani the new cases of diabetes. Again, in Europe, we have about 25,000 cases, new cases per year. In our region, it's about 15,000 cases. So, and type 1 diabetes, again, is a problem that we have to look at in our region. And different reports have shown that we are getting more and more of type 1 diabetes in our area. This is the top 10 countries for estimate number of new cases of type 1 diabetes. Of course, India comes at the beginning, then United States of America, Brazil, China, and so on. But look at Saudi Arabia. So in Saudi Arabia, we have about 2.5 or 2,500 cases of new case of type 1 diabetes. This is the number of incident cases in thousands. So we have about the 2,500 new cases of type 1 diabetes each year in Saudi Arabia. Of course, this we need to pay a special attention to this age group. And this is the top 10 countries or territories estimated number of prevalent existing children of diabetes. So how much we have of type 1 diabetes now. So in India, we have 95,000, United States about 94,000, and so on. We have one here Arab countries, Algeria with 20,000 and Morocco with 16.4 thousand. This is the top 10 countries for the incidence rate of type 1 of per 100,000 population. So per 100,000 population, in Finland, they have 62 cases. In Saudi Arabia, we have 30. So we have about 50% of the rate in Finland is 62, Saudi Arabia is 31, and we are here number 5, as you can see in Saudi Arabia. Qatar comes less than us with 28 cases per 100,000 population per year in the age group of 0 to 40. And this means that we are one of the top countries in the newly cases of type 1 diabetes each year, Saudi Arabia. Now, the new data, the diabetes in the world, as you can see it in the International Diabetes Federation, North America has got about 51 million. In South and Central Asia, there are 32 million diabetics. In Africa, only 24. This is the least number. In Middle East, in our region, we have 73,000 million of diabetes. We are more than Europe with 61 million patients with diabetes. Southeast Asia, 90 million. And of course, Western Pacific, where China is, they have 200 million patients with diabetes. So our region, in the Middle East, in 2021, we have 73 million. Now, inshallah, the IDF Diabetes Atlas, the 10th edition, the new data will be available to download on December 6th this year. So 1 month from now, inshallah, you will get the new data from the International Diabetes Federation about the prevalence and epidemiology of diabetes. With that, I would like to thank you, and if you have any question at the moment or maybe later on, I'll be really happy to answer you. Thank you very much.
Thank you, Dr. Khalid, for informative presentation. We'll leave the question at the end of the session. For all, if you want to ask, you can put your question in chatting. Let's see at the end of the session. Now, Dr. Humaid al-Sahafi is consultant of internal medicine and endocrinologist at Hira Hospital in Mecca. He will highlight on different types of diabetes and the updated diagnosis categories and criteria for diabetes. Welcome, Dr. Humaid.
شكرا دكتور فيصل. أشكر السلام عليكم ورحمة الله وبركاته. أشكر الجميع على الحضور اليوم، وأشكر خاصة الدكتور خالد الطيب للدعوة الكريمة للمشاركة في هذا المؤتمر. بسم الله الرحمن الرحيم. As we know, diabetes is a common disease, and in treating diabetes, we should know the type of diabetes. For this reason, we should know the type of diabetes to treat patients either with oral hypoglycemic or with insulin, or with will search about any familiar predisposition for diabetes, special type of diabetes. As we know, the common type of diabetes is type 2 diabetes and type 1 diabetes and gestation diabetes. And also there is another types of diabetes arising in the floor and it's genetic related diabetes, and we'll talk about in the following slides. As we know, the pathophysiology of usual metabolism of glucose. Glucose is taken from the gut, and also the insulin is helping glucose to enter the cell to be utilized as energy source. So the insulin role is helping the glucose to be heavy, entering to the cell to be utilized as energy source. So this is the usual physiology. The pathophysiology of type 1 diabetes is usually no insulin. So no glucose can be entered the cell to be utilized as energy. So no energy for the body, and also it's lead to accumulation of blood glucose in the blood. So hyperglycemia and hyperglycemia symptom, polyuria, polydipsia, and then is diabetic ketoacidosis. Type 1 diabetes is account for 10% of diabetic patients. They have type 1 diabetes. 90% of type 1 diabetic is immune related, and 10 of them is idiopathic, so no clear cause to cause the type 1 diabetes. As we know, the immune related diabetes type 1 is 90% of type 1 diabetic patient. Diabetic type 1 is related to immune mediated. So the immunology, it had role for pathophysiology of the type 1 diabetes, and it had a genetic predisposition, and there is these autoimmune leading to autoimmune discretion of the beta cells, leading to absolute deficiency of insulin secretion, and leading to the acute onset of catabolic symptom and diabetes ketoacidosis. And usually this is the presenting symptom at diagnosis. Immune-mediated type 1 diabetes is associated with autoimmune disorder. Other autoimmune disorders can be associated with type 1 diabetes in the form of the autoimmune syndrome, and leading to the low C-peptide and endogenous insulin or absolute deficiency of insulin. About 30% of these patients developed the diabetic ketoacidosis at the onset of diagnosis. And of course, because no insulin, so the insulin is the only treatment choice for this type of patients, and they need lifelong treatment with insulin. So the immune-mediated type 1 diabetes is caused by autoimmune syndrome. There is autoantibodies is common in these type of patients. The most common autoantibodies is presenting in the type 1 diabetes immune-mediated type 1 is anti-glutamic acid decarboxylase antibodies, which is the most common autoantibodies presenting in type 1 diabetes, and followed with the anti-zinc transporter 8, this is the second common autoantibodies presenting in type 1 diabetes, followed with also the low level of the anti-insulin antibodies and also insulinoma-associated protein 2 antibodies. Idiopathic type 1 diabetes is most, it's 10% counted of type 1 diabetic patients had idiopathic, no clear cause for this type of diabetes, and share the same feature of type 1 diabetes and can be presented with diabetic ketoacidosis. And it accounted for 5 to 10% of type 1 diabetes. Staging of type 1 diabetes, usually type 1 diabetes it had three stages. early stages with especially autoantibodies presenting in the bloodstream. Stage 2, the autoantibodies causing pre-diabetic stage with the fasting hyperglycemia and also postprandial hyperglycemia. And at the diagnosis, the patient presenting with symptom of hyperglycemia and diabetic ketoacidosis in the onset of type 1 diabetes. Type 2 diabetes is the most common type of diabetes, and involving 90% of diabetic cases worldwide, and it's caused by insulin resistant and usually decrease insulin secretion in this type of patients, and it's common in the family, so there is a strong family history of diabetes in this type of diabetic type, and usually it's most common in the overweight patients. It treated this type of patient treated by oral hypoglycemic, and some patient needs insulin to help the oral hypoglycemic to overcome the hyperglycemia. And the pathophysiology of type 2 diabetes, there is insulin, so no absolute deficiency of insulin. The insulin is maybe diseased or not enough insulin secretion to overcome the hyperglycemia. So there is a little amount of glucose used to be utilized in the cell, but there is accumulation of the glucose in the bloodstream. So there is symptom of hyperglycemia. So why the type 2 diabetes is happen? Because there is decreased insulin secretion, increased glucose secretion, and there is also impaired the incretin action, and there is also impaired in utilization of glucose in the peripheral tissue, which cause also the hyperglycemia in the blood, and also there is increased hepatic output of glucose and increased gluconeogenesis, leading to the hyperglycemia and hyperglycemia symptoms. This is the slide shows difference of the between type 1 and type 2 diabetes. In type 1, there is no insulin, so there is absolute insulin deficiency causing the hyperglycemia and hyperglycemia symptoms. And this on the right of the screen shows that there is type 2 diabetes with there is presence of insulin, but no not enough insulin, so there is accumulation of the blood glucose in the blood causing the hyperglycemia symptom. This is how we differentiate type 1, also type 2. Type 1 is usually the age of patient less than 25, but the type 2 usually age of patients is more than 25 age. Weight usually in type 1, the patient is looked thin or catabolic in the catabolic state, but in the type 2 usually overweight. 90% of these patients have obesity or overweight. The autoantibodies is present in type 1, but the negative in type 2. DKA is most common in type 1, but it can be happen in type 2, but low rate. And the family history usually in type 2 more common. 90% of patients, they have family history of type 2 diabetic patients, and 5 to 10% in type 1, they have family history of diabetes. The third most common of diabetes type is gestation diabetes. This diabetes is diagnosed first time in pregnancy, usually in the second or third trimester, because there is insulin resistant and counteract hormones causing the hyperglycemia during pregnancy. And 50% of these of patients, they have normal blood sugar after pregnancy, but they have risk to develop another attack of gestation diabetes and following diabetes, and they have 50% chance to develop diabetes type 2 in the future. And there is interesting type, usually it's arising nowadays in our patients, called latent autoimmune diabetes in the adulthood. This type of diabetes is usually seem like type 1 diabetes, but these patients usually they have type 2 diabetes and ended by autoimmune destruction of the beta cell of the pancreas, causing type 1 diabetes symptom. So these patients late onset autoimmune diabetes in the adulthood, usually they have type 2 diabetes, but ended by destruction of the beta cells of the pancreas, causing type 1 diabetes. And in the some literature called this type is 1.5 diabetes. So this LADA, it's caused by autoimmune destruction of the beta cell of the pancreas, leading to type 1 diabetes in the adulthood. There is another rare specific types of genetic related diabetes. The most common monogenetic diabetes is maturity onset, MODY, neonatal diabetes, mitochondrial DNA defect, and other type of diabetes. MODY, it's a common genetic disease at the age of the patient less than 25, and also the patient is not overweight. There is strong family history of diabetes and MODY. It also autosomal dominant runs in the family, and there is no negative autoantibodies in these patients. And also, it counted 1% of all diabetic patients in the United States inherited autosomal dominant. There is defect or mutation in 13 gene different chromosomes due to impaired insulin secretion, no defect in insulin action. DKA and sign of insulin resistant are unusual. There is around six forms or types in MODY, but the most common types in MODY is MODY type 3. It's counted 50% of the MODY diabetes, and it's responding well by sulfonylurea. And there is MODY type 2, 30% counted in MODY types, and it responds to diet only. And some types of MODY is responding to insulin. So if the patient is not responding to sulfonylurea or diet, you can add insulin. And how to diagnose this one is diagnosed clinically. The patient is less than 25, no history of DKA, strong family history, and you can do the genetic testing for MODY diabetes. And the neonatal diabetes is a genetic form of diabetes. It's rare, affected 1 in 200,000 births, usually developed within 6 months of birth. It's associated with a single gene mutation, and clinical feature decrease birth weight and decrease fat store and hyperglycemia. Neonatal diabetes can be either transient or permanent. The treatment usually with high dose of sulfonylurea. So the other rare types of diabetes is mitochondrial diabetes. Is usually defect in majority of patients by mitochondrial gene mutation. Treated by metformin is contraindicated due to the risk of lactic acidosis. Is predominantly maternal transmission of disease. It's associated with sensory neural difference. Genetic defect in the insulin secretion, in the insulin action, type A insulin resistant, Robson syndrome, and lipodystrophy, and other type of genetic defect. And disease in the exocrine pancreas, it's common causes, usually trauma of the pancreas, cystic fibrosis, acute chronic pancreatitis, pancreatic carcinoma, and hemochromatosis. And also the cystic fibrosis is related diabetes is rare causes of diabetes. Annual screening with the oral GTT should be begin in patient with cystic fibrosis at age of 10 years, usually treated with insulin. And the usual diabetes can be accompanied with other endocrinology disease like Cushing syndrome, acromegaly, pheochromocytoma, gluconoma, and also somatostatinoma, and also the hyperthyroidism. So the diabetes can be accompanied with the endocrinopathy. Also, there is a type of diabetes is related to the drug induced. The most common drug related diabetes is glucocorticoid related, and also alpha interferon and thiazide loop diuretics. And there is viral predisposition to diabetes, usually congenital rubella, cytomegalovirus, Coxsackie virus, adenovirus, and mumps can in some studies they showed maybe related to type 1 diabetes. Also, uncommon form of immune-mediated diabetes, Stiffman syndrome, anti-insulin receptor antibodies, and also other causes. And also there is associated diabetes can be associated with other genetic syndromes like Down syndrome, Klinefelter syndrome, Turner, Wolfman, and Friedreich ataxia, Huntington chorea, and also myotonic dystrophy and porphyria. Prader-Willi syndrome can be associated with diabetes. So in summary, the common type of diabetes is type 2 diabetes, responding to the oral hypoglycemic and diet. Some patient needs insulin therapy. Type 1 diabetes, usually due to immune related and responding well to insulin, and patient needs insulin lifelong. Gestation diabetes, the third common diabetes type, and responding to the diet and insulin, and also arising some specific times is moody, LADA, and genetic causes of diabetes. And as Dr. Khalid mentioned before, the criteria of diagnosis of diabetes, usually it's 4 criteria: fasting blood sugar more than equal 126 milligram per deciliter, 2 hours after GTT is more than or equal to 200, and random blood sugar with symptom more than equal to 200, and hemoglobin A1C more than equal 6.5. So also as Dr. Khalid mentioned before, there is we should memorize the criteria of diabetes and also the pre-diabetes. So it's related to the how we treat the pre-diabetic and diabetic patients. Usually pre-diabetic patient hemoglobin A1C from 5.7 to 6.4, fasting blood sugar and pre-diabetic 100 to 125, and 2 hours postprandial glucose tolerance is from 140 to 199. So we should take in consideration there is important points in diagnosis of diabetes. In equivalent hyperglycemia, the result should be confirmed by repeated test. If you have one test, you should repeat it for confirmation. Don't depend on one single test for diagnosis of diabetes. And if you have different tests like fasting blood sugar and hemoglobin A1C, diagnosis of diabetes is positive, so you can easily diagnose diabetes. And taking in consideration, fasting blood sugar should be 8 hours fasting using serum blood glucose, not by glucometer. So fasting blood sugar should be fasting 8 hours and with using serum sample. And if there is different contradicting result like hemoglobin A1C or fasting blood sugar, one showing diabetes range and the other showing a not diabetic range, you should repeat the test which shows diabetic range. So if the hemoglobin A1C high and fasting blood sugar in the pre-diabetic range, repeat the hemoglobin A1C. So for make the simplified things, there is one test your knowledge, which these patients is diabetes. A. Ahmed, hemoglobin A1C 6.6 taken after breakfast. B. Fahad, plasma glucose level 100 milligram after only a cup of juice. Samia, hemoglobin A1C 5.2. Or Mona with symptom of polyuria or polydipsia and no glucose, no hemoglobin A1C abnormality. So which these of patient have diabetes? Think about it and for 30 seconds, then we'll answer this one. So Ahmed, he had hemoglobin A1C 6.6 and Fahad had plasma glucose 100 and Samia had hemoglobin A1C 5.2 and Muna had symptom with no test. So Ahmed, he had hemoglobin A1C above 6.5. So it's need to be confirmed. So it will not depend on the single blood test to diagnose diabetes, as the American Association Diabetic Association guidelines for diagnosis of diabetes. You should, if you have one test, you should repeat to confirm, or you have a different two tests. Fahad had glucose 100, so in the range of the pre-diabetic, so it's not diagnosed diabetes. Symptom alone is not enough to diagnose diabetes. You have to confirm the symptom with the lab diagnosis by hemoglobin A1C or the fasting blood sugar 8 hours serum sample. Hemoglobin A1C 5.2 is not in the diabetic range, even it's not in the pre-diabetic range. And this case is practical. I will end my talk with this practical case. 76 female patient came with a routine checkup. She didn't have any symptom of polyuria, polydipsia, body mass index. She is obese, fasting lab 14 hours, fasting blood sugar is 180. So the hemoglobin A1C is 6.3, creatinine was normal, and also the other chemistry is normal. So she had obesity, and she had fasting blood sugar in diabetic range, hemoglobin A1C and not in the diabetic range. What will you will do next? Start metformin 500 milligram daily, gradually increase the dose 1 gram daily and weekly basis. So she is diabetic now. B. Sulfonylurea, start sulfonylurea and Janufia. C. Repeat hemoglobin A1C. D. Repeat fasting blood sugar. E. None of the above. So think about it, and for 30 seconds, then we'll answer it. So the correct answer, repeat fasting. I think repeat the fasting blood sugar, which shows the diabetes as the criteria. The criteria, if there is contradicting result, repeat the test which shows diagnosis. So the abnormal is hemoglobin. The fasting blood sugar is 180 in diabetic range, while the hemoglobin A1C is not diabetic range. So to confirm the diagnosis, repeat the tests which shows diabetes. It means repeat the fasting blood sugar. I thank you a lot for listening this presentation, and the floor for you, Dr. Faisal.
Thank you, Dr. Hamid, for a good review about the diagnosis and different types of diabetes. Next presentation will emphasize the type 2 diabetes is preventable disease in addition to be treatable disease. Dr. Manhal will talk about presentation of type 2 diabetes prevention. Dr. Manhal بعنوان is endocrinologist consultant at the North Specialist Hospital in Mecca. Welcome, Dr. Manhal.
السلام عليكم ورحمة الله. Thank you, Dr. Faisal, and thank you, Dr. Khalid Tayyib and the organizing committee for the invitation to participate in this an important event for the World Diabetes Day. My talk today is it's important in the prevention of the diabetes type 2, and we know that there are numbers of factors that influence the diabetes type 2 development, and the modern lifestyle characterized by physical inactivity and the long sedentary period. And as a result of the increased prevalence of the obesity and the sedentary life, the metabolic syndrome becoming a worldwide epidemic. And there are many risk factors for the type 2 diabetes development, and that's why we are looking to the ADA recommendation is to try to assess and screen for the type 2 diabetes in asymptomatic adults who had even an overweight or an obesity with a BMI of 25, and sometimes to a less BMI level of 23 in some of the ethnic groups, such as the Asian American. And these factors include the first degree relative with the diabetes, and the high risk ethnicity, and the presence of the history of cardiovascular disease or the hypertension, and even the level of the HDL cholesterol of less than 35 milligram per deciliter, or the triglyceride level of more than 250 milligram per deciliter. And women with the polycystic ovary syndrome, and physical inactivity also, and some of the conditions associated with the insulin resistance, such as a severe obesity or the presence of the acanthosis nigricans, and even with the history of a woman with a GDM history need to be assessed. And for all patients who should be tested for the diabetes diagnosis to begin at the age of 45. It is well known by many studies that the impaired glucose tolerance associated with the macrovascular and the microvascular complications, including the neuropathy and the MI or the acute coronary syndromes. So there are relation of the cardiovascular disease with the prediabetes and the impaired glucose tolerance test. And as it's well known that the effect of the insulin resistant and the hyperglycemia play a role in the cardiovascular disease pathogenesis. The obesity itself and the insulin resistance and the obesity itself will increase the free fatty acid levels and the reactive oxygen species, which will stimulate and activate the inflammatory markers and lead to the endothelial dysfunction. In the HOPE study, the heart outcome prevention evaluation, the risk of the cardiovascular events, including the MI, stroke, and the cardiovascular death in the following 4.5 years increased by almost 9% with every 1 millimole increase in the fasting glucose. And every 1% increase in the A1C was also correlated with a higher risk of the cardiovascular outcomes. And these relationships were independent of the other cardiovascular risk factors such as the age or sex or the blood pressure and the hyperlipidemia, and remain significant even after the adjustment for the diabetic status. And in another study, the current definition for diabetes relevant to mortality risk from all causes in the cardiovascular and non-cardiovascular disease titled, it shows that there is a correlation between the fasting plasma glucose and the cardiovascular disease-associated mortality independently of the diabetes status. And this relationship between the fasting plasma glucose and the cardiovascular disease mortality seems to be a J-shaped curve with no threshold effect observed at the high glucose level. And in another prospective study of the non-diabetic patient admitted for MI with the blood glucose level of less than 11.1 millimole shows that 35% of those patients were found to have an impaired glucose tolerance at the time of the discharge. And even 3 months after follow-up, 31 of them fulfilled the criteria for the diabetes. So in addition to that, we know that, as previously mentioned, the total health expenditure on the diabetes by the IDF region, it is high and it is increasing even over years. And also it was spent to the diabetes related complications. So I will come with you or review with you the type 2 diabetes prevention studies, and I will mention, there are many, and we'll mention the most important of them. One of them is done in China, the duck-wing IGT and pre-diabetes study, which examined the effect of the 6-year diet and exercise intervention in China in Chinese individuals with an impaired glucose tolerance with an average age of 45 years. The proportional hazard analysis reduction in the diabetes type 2 development was 32% in the diet group, and it was 46% in the group with only have an exercise intervention, while the diet and the exercise intervention reduced the risk by 42%. And the long-term effect of those lifestyle intervention to prevent diabetes in the same study up to 20-year follow-up shows the same results. And this figure shows the cumulative risk of the diabetes type 2 development at 6-year intervention and at 20-year or during the 20-year follow-up. And it is less in the intervention group. And again, the cumulative incidence of the all-cause death, it was during the follow-up in the period of the study was less with the intervention group. And again, this figure shows the cumulative incidence of the first cardiovascular disease event during the 20-year follow-up period. And the same result shows that the cumulative incidence of the cardiovascular disease were less in the intervention group comparing to the control group. In another study, the Finnish diabetes prevention study, which was a randomized controlled trial, assigned 522 overweight or obese individuals with impaired glucose tolerance. They assigned them either to lifestyle intervention or a control group, followed for 3 years to achieve and maintain the healthy body weight and reducing the fat intake, increasing fiber intake, and increasing the physical activity. And it shows here in the figure that if we are comparing from the baseline, the change was also in the weight, the waist circumferences, and the systolic blood pressure and the diastolic blood pressure in the intervention group compared to the control group. And the incidence of the diabetes development, it was even less than 50% in the diet intervention group. In the other study, and the most it is with a diverse study, even titled as reduction in the incidence of the type 2 diabetes with the lifestyle intervention or metformin. It shows that the cumulative incidence of the diabetes in all groups, it was less in the or it's more in the lifestyle group compared to the other intervention group. And shows that the reduction in the incidence of the diabetes with the lifestyle intervention reach up to 58% who are on the diet and exercise group, while the group with metformin only, they have a 31% reduction in the DM development compared to the placebo group. And this effect of the delay in the incidence of the diabetes mellitus, it even persists 10 years after in the diabetes prevention program outcome study. And in another, an Indian diabetes prevention program, which shows that the lifestyle modification and the metformin prevent the type 2 diabetes in Asian Indian subjects with impaired glucose tolerance. The difference in this study compared to the previous mentioned study, it was tested in the Asian Indian with impaired glucose tolerance who were younger, leaner, and more insulin resistant than in the multi-ethnic American, Finnish, and Chinese populations. So it shows that the progression of the IGT to the type 2 diabetes is high in the native Asian Indian, and both the lifestyle modification and the metformin significantly reduce the incidence of the type 2 diabetes in those population. The effectiveness of different intervention can be measured with a different indicators, such as the year of life gained, the quality adjusted life years, the disability adjusted life years, and the number of diabetes cases prevented and number of diabetes cases identified. And the aim of the cost-effective analysis is usually to evaluate the cost and the health effect of the specific interventions. This is the incremental cost-effective ratio. It is a statistic or an indicator used in the cost-effective analysis to summarize the cost-effectiveness of the healthcare intervention. And it is defined by difference in the cost between the two possible interventions divided by the difference in their effect. I mentioned all of these in order, so that's why the IDF have a systematic literature review to assess the cost-effective solutions for the prevention of the type 2 diabetes. And in order to summarize the available data as regard the cost benefit of the primary prevention of type 2 diabetes, this systematic literature was conducted. And out of 71 intervention analyzed in, it shows that 14% of those test intervention was cost saving, and reaching up to 67% of them are cost effective. So this figure shows the cost effectiveness by the type of the intervention based on the ID 50,000 acceptance threshold. So it shows that with the different and variable interventions available, most of them, they are cost effective, and 3 of them are cost saving, which indicate that we have variable interventions available that can be cost effective. And in studies that compare the individual and the group intervention with the cost per quality adjusted life year gained from the health system perspective, it shows that the intervention delivered to the group of participants were more cost effective compared to the individual to those delivered to the individual setting. Here, this figure shows that the cost effectiveness of the lifestyle intervention complemented by medication, and the medication was tested either the orlistat, metformin, or the acarbose, and the targeted group either the who are the people with obesity or impaired glucose tolerance in either a health system perspective or in a society perspective. And most of these interventions, really, it is a cost effective. Metformin, it can be a cost-effective medication for the primary prevention of type 2 diabetes. In 9 studies here shows that which shows the cost per quality adjusted life year gained for the metformin therapy. Most of these studies are showing that the metformin is a cost-effective, and some of the studies shows that it costs even saving. So what is the effect of the lifestyle modification on the metabolic syndrome, which was reviewed in a systematic review and meta-analysis done in 2011, which evaluating the effect of this lifestyle modification on the metabolic syndrome, either by its resolution or improve the values of its component. And really it shows that in many of or 8 random randomized trials shows that the relative proportion of the patient with resolved metabolic syndrome in the intervention group was 2 times greater in this group compared to the control group. And this intervention significantly reduced the mean value for the systolic blood pressure, the diastolic blood pressure, and the waist circumferences and the fasting blood glucose level, but not significantly for the HDL level. So that's why an IDF recommended the comprehensive lifestyle program for people with impaired glucose tolerance, and to choose as they are cost effective from a health system perspective, and even it is a potentially cost saving from the societal perspective. The local adoption of the comprehensive lifestyle program are good alternative to a lower resource setting, and the metformin can be considered as a cost effective strategy for the type 2 diabetes prevention, in addition combine or alongside with the comprehensive lifestyle program. And use the public health measure. The public health measures to promote the healthier diet shows promising result regarding the cost effectiveness for the primary prevention of type 2 diabetes. In 2014, the WHO guideline recommend the adults and the children to reduce their daily intake of the free sugar to less than 10% of their total energy intake, and even to further reduction in less than 5% per day would provide an additional health benefits. And to support this recommendation, the IDF published the IDF framework for the action on sugars, and some of the countries even they are trying to apply taxes for those the high sugar food intake, and this is really help much in helping population to prevent diabetes type 2 as a public health measure. Here's some of the IDF recommendation for the healthy diet for the general population, and you can see that in the IDF reports. And thank you so much.
Thank you, Dr. Manhal, for a nice presentation, informative about the prevention of major killer disease, and it's running fast in our peoples around Arabs and non-Arabs. Now, coming to the questions and comments attendees, we have any questions from attendees? We have one debate and dilemma about the diagnosis. In our clinical presentation of type 1 diabetes, now we have many cases mentioned by Dr. Hmaid Sahafi about type 1 diabetes presented a diagnosis with obesity. And we have C-peptide insulin level available in our hospital. The question is, what's the role of C-peptide and insulin for diagnosis and differentiate between type 1 diabetes and type 2 diabetes? Can help us in diagnosis and differentiation.
Thank you, Dr. Faisal, for this practical question. Usually, type 1 diabetes is presenting with diabetic ketoacidosis. As you said, nowadays is arising cases of obesity, usually in children. It's mimic type 2 diabetes. It's confusing type 1 and type 2. But usually C-peptide and insulin level in the acute state of the hyperglycemia is not diagnostic. So we cannot depend totally on C-peptide and insulin level in the early stage of type 1 diabetes in the hyperglycemia state. So if the patient later on the blood glucose stabilize, usually we take a hint of the or help of the insulin level and C-peptide level. Usually it's be below the normal level in type 1 diabetes. And I think as a recommendation, you should screen for autoantibodies to diagnose diabetes in this special type. Usually to make sure that a patient after stabilization of the hyperglycemia and return back to hemoglobin A1C to the normal level, to shift the patient on sulfonylurea or not, or oral hypoglycemic and stop insulin. This one depends on the autoantibodies. If autoantibodies is positive, it's difficult to stop insulin. So usually for practical point of view, start insulin therapy in this type of patient, usually in young patients less than 25 years presented with the diabetes. Then search about the cause. If it's autoimmune, type 1 diabetes, usually screen for C-peptide and insulin level if the stabilization of the hyperglycemia, and also do the autoantibodies. The most common autoantibodies, as I said before, anti-GAD antibodies, and nowadays also zinc transporter 8. But zinc transporter, it's very expensive now. It's cost around 3,000 Saudi riyal, and it's very costly, and also it's not available in MOH. Maybe it's will be available later on, I don't know. But if you highly suspect type 1, start with insulin and search, take the help of C-peptide and insulin level, and if the blood sugar stabilized.
Okay, Dr. Mayed. For Dr. Manhal, usually they are asking about other agents other than, leukophage for prevention of type 2 diabetes or delay the progression from, type diabetes to type 2. Question: we have another studies on, for example, on actors and other agents to help them forming for this aim.
Yes, really, there are many medications, but I didn't highlight it much in the presentation today. Yes, the orlistat, the acarbose, even the some of the studies, the ramipril to reduce the cardiovascular events. Yes, there are some of studies which showed the use of those medication can help in preventing type 2 diabetes. Really, the metformin and the orlistat was the most cost-effective medication that can be used as a medication. Yes.
Okay, thank you. I think no more questions or comments. Have time for this question. If any comment for speakers from Dr. Khalid, Dr. Mayed, Dr. Manhal, for time being now.
Actually, I would like to thank all the speakers, Dr. Hamid, Dr. Manhal. I'd like to thank also our chairman, Dr. Faisal. Alhamdulillah, if you don't have any more questions, then we will end this session now, and we will take 15 minutes up to 10:30. And inshallah, Dr. Bandar will chair the session at 10:30. So we'll be about half an hour ahead of time, which is good for us. And for that, we'll have a little bit of change in schedule. So I will be giving my lecture also in the second session rather than the third session. And by that, maybe inshallah, we will end before Salat al-Asr. Inshallah, we'll be ending our program. So with the permission of our chairman, Professor, we end this session now, and we will start, inshallah, exactly at 30. Thank you very much, and I hope, inshallah, continue on schedule, and we will try, inshallah, to finish up for Salat. Thank you very much. السيشن الأول خلصنا السيشن الأول شوية الحمد لله يعني قريب شوية. فالسيشن الثاني إن شاء الله حيبدأ بعد قليل. رئيس الجلسة الدكتور بندر دمنهوري. السبيكر الأول حيكون الدكتور محمد نور، لكن يبدو أنه هو جاهز شوية. بعد إذن الدكتور بندر حقدم أنا المحاضرة حقتي اللي هي كان مفروض في السيشن الثالث، أقدمها أول، وبعدين الدكتور محمد نور، بعدين الدكتور فيصل بالكي. دكتور حميد اعتذر عن الشيرمان على الجلسة الثالثة، فحكون أنا إن شاء الله شيرمان الجلسة الثالثة بدل الدكتور حميد، أنه عنده ارتباط. الله خير. هذه التعديلات البسيطة اللي أرجع لسعادة رئيس الجلسة. تفضل.
طيب، شكرا دكتور خالد. السلام عليكم ورحمة الله. Welcome everybody. It's our pleasure here to be with you here in جمعية شفاء. Thanks for the invitation from Dr. Khalid and colleagues, and hopefully it should we have a nice meeting today and in the World Diabetes Day to remind our healthcare providers about the diabetes management and update in diabetes field. Every year we have this meeting to remind ourselves, and hopefully that we have a successful management of diabetes every year. So without further delay, we'll go as mentioned by Dr. Khalid now for the his topic. His topic is proposal for diabetes care management. It should be in the third session, but we modified it to be here. It should be presented by Dr. Khalid Tayyib. Dr. Khalid Tayyib, as you know, he is a senior consultant endocrinologist, diabetologist, and he, mashallah, he is the head of جمعية شفاء currently in Mecca. So let's listen to his topic. تفضل دكتور خالد.
السلام عليكم ورحمة الله. I hope سامحوني شوية. مصطفى راحت الصورة. اوكي هذا ان شاء الله تكونوا سامعيني كويس.
ممتاز.
طيب بسم الله الرحمن الرحيم. حقيقة لا شك انه كل الحاضرين اليوم هم خبراء في رعاية مرضى السكري، وانا سأستعرض معكم اليوم proposal انه احنا كيف نقدر نحسن رعايتنا لمرضى السكري بدون ان يكون علينا تكلفة اقتصادية عالية، وفي نفس الوقت تكون رعايتنا لمرضى السكري افضل من الوضع الحالي. ما انت شايفين السلايدات كويس؟ انا دكتور بندر.
واضحة يا دكتور خالد، واضح.
اي طيب. What I'm going to present is a proposal for an optimal diabetes care model, what we call a value-based approach. نرجع شوية على وراء في تاريخ. في 2013 Alhamdulillah, in Saudi Arabia, we have started the project of diabetes centers. And more than 20 centers are now in function in Saudi Arabia. But when we did at that time, the guidelines for management of type 2 diabetes, we made it on what we call a referral system. So the patients used to go to the primary health centers, as they do now, and then they are referred from the primary healthcare centers to what we call diabetes units in the hospitals, and then maybe later to diabetes centers, because not each hospital has got the diabetes center. and not each patient is referred to diabetes center. Sometimes patients are referred to hospitals and then they're referred to diabetes center. This is the recommended sort of protocol that was published in 2013 by the MOH guidelines for diabetes by the Ministry of Health. And of course, this system is still valid and we're still applying this system. Now we want to see, can we improve that? Can we do something better than this? Okay. Now, so currently, the diabetes management is based on what we call a retrospective data evaluation. So what we're doing at the moment is that we are looking at risk-specific data, and based on that, we are doing our care plan. So either we are filling sheets, manual by hands, or software, or we're taking snapshots of the data obtained by the patient on his visit. Now, this sort of management actually is what we call a retrospective management. Why? The disadvantage here is the damage from the disease has already taken place. Now, we give patients appointments and we tell them, please come after 6 months. Now, maybe in these 6 months, patients has already developed complications. But what happens, we always look at the patient retrospective data. So patient, maybe he developed, let's say, hypertension, or developed nephropathy, or developed retinopathy, or neuropathy, or whatsoever. And we only know this when the patient comes to us in the clinics. It could be 3 months later, 6 months later, or sometimes even, and I know some places where they give patients only 1 year follow-up. So this sort of management is based on a retrospective data that, of course, can make the patient suffer for some time before he comes and his patients are doctor. Now, this type of management or retrospective looking at patients' data is not always good, because diabetes is a disease that requires the patients to do self-monitoring at home. He has to take regular medications. He has to be restrictive in diet, and he has to do exercise. Now, we don't know whether these patients during this 6 months period, or 1 year period, or 3 months period, whether they are really compliant of the recommendation made by the treating team. So you will have nothing to know about whether your patient is taking his medication as you did want them to do that, whether they're really self-monitoring or they're not self-monitoring, we don't know. Are they following diet or not? We don't know. Are they doing exercise or not? We don't know. So to have a proper care for patients with diabetes, we should be alert about these recommendations that we make to our patients, and whether they are following this or not. And of course, that diabetes is a disease of chronic complications. It's almost all organs in the body. Definitely, you get microvascular complications and macrovascular complications. And of course, you want to pick up these complications before they occur, or at least which one of the patients is more likely to develop these complications. Now, with current sort of management or care plan is sometimes too late. So we only see our patients when they have already developed these complications. And we need another system that will allow us to identify early those patients who develop complications. Now, this is why our proposal depends on what we call a proactive approach. To do that, we'll definitely need artificial intelligence because it will definitely help us to know more our patients, to follow up more our patients, and to be able to recognize those who are at least. So the thing is depends on medical devices and digital transmission of data. If you have these, then you can apply what we call a proactive approach using artificial intelligence. You can have patient data analysis response immediately. You can have a minimal change in human schedule and a continuous assessment. So your patient doesn't need a lot of change in his daily schedule to contact you. So what he needs is only minutes or seconds sometimes just to contact you and tell you and talk to you and give you his data, and maybe you give him a response that will help him to keep him well during or in between the timing that you're seeing him actual in your and this of course will give you what we call a continuous assistance. So you are not missing your patient between your appointments. You're not missing your patient for 6 months and then you see him. Your patient will be always in contact with you. You always know about his condition, about any change that will happen to him, and of course you will be in support for him all the time. So it will give you a continuous assessment for your patient. Now, all health systems now is dependent on what we call a value-based healthcare. What is a value-based health-based care? Is a patient health outcome achieved versus the amount of money spent to those outcomes. So you get a budget that you want to spend on your patients, and of course you want to get the best benefit of that budget, which will be reflected on the health of your patient. This is what we call a value-based healthcare. So we want a better outcome with less cost. This is the equation here. You can see that value equals the outcome divided by the cost. So you have to increase your value by improving the outcome of your patients, and in the same time, you reduce the cost. This is the accepted sort of trend in the management of any health system around the world. So proposal for optimal diabetes care will be like this. Improve care and outcome of people with diabetes in urban and rural. And I've written this, is very important, urban and rural, because you will not be able only to follow patients in your urban places, but also in rural places you can follow these patients. What we need to do is you need to transform our care in what we call a chronic care model. Chronic care model means you have to have the right care for the right patient, the right time, and the right place. This is what we call a chronic care model. Okay, and we have to utilize artificial intelligence. Without artificial intelligence, you cannot achieve that. Sorry. And we need to solve the current deficiencies and difficulties. Now, what are the current deficiencies and difficulties that we have? I'm sure you know it maybe better than me. Those who are working in the diabetes care, seeing patients daily, I know that they got problems with patient education. They have problems with appointment and seeing most patients. Maybe they know they have appointments later than their patients need. They have appointments with so they have difficulty with maybe financial difficulties, and a lot of difficulties exist, and I'm sure that you know it. Maybe also in staffing, you might have difficulties in staffing, and you don't have enough staff to see all your patients at the right time that you want it. So we need to solve these problems. And you have, of course, we have to educate patients, families, and the caregivers. And of course, we need to reduce the cost, because as you have seen in my previous lecture, the number of people with diabetes will continue to rise. And unless you reduce costs, you will not be able to cover the needs of all these patients, unless you use a better model of care, which improve the outcome and reduce the cost. Now, we have also to ensure clinical, what we call clinical guidelines-based delivery of care. Our care should be based on guidelines which tell us when, for instance, to look at the fundus, which tell us how to manage blood pressure, how to manage obesity, how to manage and so on, other clinical problems. So each patient will be having a clinical guidelines-based delivery care. We have also to encourage what we call a patient-centered medical home model, and you can see in this diagram what we call a medical home care or model, and this will depend, of course, on self-management support. So the patient should be supported, and for that, of course, we have to make a tailoring of the patient's goals. So we have to put a goal so the patient, whether is an elderly or a young or a pregnant or not pregnant or so on, you have to have a self-management support and a regular review of the patients as needed per case, and a navigation of care, and of course, health coaching and education. We have to implement an outreach program. We should have some mobile units, especially in rural areas. Alhamdulillah, in Shifa, we have such a unit in which you visit people who you are not able to reach them, for instance, through internet or so. You have to have a mobile unit which can help you. You have to improve patient self-care, compliance, and quality of life. And of course, we have to encourage the non-profit organizations like Shifa to share in patient care, because governmental services might not be enough to cover all the needs that you need, or the care needs, and you have to support the medical research and the data management. All of this can be done through a remote monitoring and software partners who can help you to monitor your patients and to download all their data, not only blood glucose, but you can download a lot of data from your patient, their weight, their blood pressure, and their even temperature, even if you want to have other clinical parameters, you can download it. So what you need is devices that you and your patients use. And of course, you need a health buddy. You get a place or organization, a hospital, whatever it is, command center who will give information to the patient. Of course, an application that is shared by both the patient and the caregiver. This is an example. Here you have a customized ranges and responses. So you have here blood pressure and so on, other parameters. You need medical staff, and of course you have to have a server which download your data and keep them safe. That is one of the applications that is available now. Through that application, you can have appointments online. You can book a physician consultation. So your patient can talk to you. He can book an appointment to talk to you, and you can get all the health statistics, visual analysis of data in the application. Home care test schedules can be reminders. For instance, if you need your patients to do fundoscopy next week, so you can have a reminder for the patient that you should come and do that. A web portal online for patients to download their data, an easy upload of lab results. If they did home monitoring or if they did even other lab tests, you can download it, and they can get prescriptions online. So if the medication is over or finished, or they need more drugs, you can do it for online, and audiovisual calls, so you can see, not only hear your patient, but you can see them, alerts and notification, tracking and monitoring, dashboard, and symptom checkers. So all of these services can be done on remote basis. On remote basis, you can do all of these. So you can see here that now you know your patients more. You don't wait 6 months till you see your patients and get there. That this is an example of a system checker. So patients can write his symptoms, and at the same time, he can have an answer on the application, whether this is red or green or yellow or in between. So the patient knows how to use this system. Behavioral nudges and reminders. Patients can have scheduled notifications of any things that you want to do or notify them. They can have appointment notification, bills and payment reminders, prescription change alerts, escalation reminders, and symptom checkers. All of this is available online. Of course, these are smart bill box, so you can know whether you have your patient taking his medication or not. You provide him with this small device in which they put their medication inside the box here, and when the patient opens his device, you get a click here that yes, visual and audible notification and medication home care. So you can know that your patient has has really taken his medication, and not only that, but you can know even the time. For instance, he took his medication 8 o'clock tomorrow, at 9 o'clock after tomorrow it was Friday, and he slept, and he didn't take medication. All of that you can know by the what we call a smart box medication smart box. Again, an application for the physicians where they can check their patient. They can have a 24/7 remote monitoring of the patients. They can have appointments of their patient. They have consultation with the patient. They can look at their patient. They can see their complaints. They can see if there is any physical sign or so. So they can have a live chat with their patients. That's how it is. You can see your patient, talk to him, see him, and answer all his responses. These are the devices that can be used by the patients and the doctors. And I can see that you can include a blood pressure monitor, a blood glucose, a bill system, a virtual ICU. Even if your patient need a monitor at home, you can see that on online. ECG, continuous ECG, you can see. There are a lot of devices that can be used and can give you a full picture of your patient. Of course, you don't need all of these devices, but depending on your patient. Now, how do we transfer diabetes care through artificial intelligence? This article, they looked at more than 450 search articles about the direct application of artificial intelligence in diabetes prevention, diagnosis, and treatment, including application devices and so on. This is a review of literature. Sorry, this is a review of 450 publications. In summary, all the publications have shown that artificial intelligence improved lifestyle therapy and self-management of diabetes and clinical decision support, and it allows a continuous and burden-free remote monitoring of patient symptoms. And it also had technical advances have helped to optimize resource use in diabetes with better glycemic control, and has introduced a paradigm shift in diabetes care. So with this, we can have definite proof that artificial intelligence could be the future and in patient management, and can help us to transform our care into what we call value-based care. This is the chronic care or implementation of chronic care models, depending on the health system and caregiver, and how this diagram to show you how this is interlinked. And with the implying chronic care model, you will get the benefits of medical indicators improvement, patient compliance enhancement, health behavior promotion, illness care satisfaction, and medical burden decompression. All of this is benefits of applying value-based care through artificial intelligence. So what are the indicators for improved outcome? Metabolic indicators like A1C, lipid profile, and EGFR, and so on. clinical indicators like body weight, blood pressure, etc., diabetes chronic complication rate, hospitalization and mortality rate, patients' awareness and compliance level, patient satisfaction and quality of life, and the knowledge of adopting clinical guidelines among healthcare. All of these outcomes have to be have proved to improve through artificial intelligence and value-based care. With that, I come to my end of my session. End of my talk. If anyone is interested to know more about artificial intelligence and the use in diabetes care, we're going to have a training session, inshallah, next week. So if you are interested or anybody is interested, we can have a training on that, inshallah, next week, and we can arrange it. You can contact me, and we will, inshallah, arrange for you to have some training on the use of artificial intelligence in diabetes. Thank you very much.
Thanks, Dr. Khalid, for really nice presentation. And this is the purpose of such a meeting, to know the technology, to know just Dr. Khalid, just the mic. I mean, it's very nice, and this is the purpose of such a meeting, and it shows us the future of diabetes, and this is the hope of diabetes patients. So every year we have something new, so they have a hope every year. So with this technology, inshallah, we have a better control for diabetes patients. Let's go now for the next topic. I think Dr. Muhammad Noor is around now. So let's start his topic. Dr. Muhammad Noor, he will give us a brief about the role of diabetes educator. And Dr. Muhammad Noor is a medicine graduate. He has hold MBB CH from Al-Azhar University, Egypt. He has a diploma and master in pediatric from Ain Shams University. Master and MD in Public Health Community Medicine from Al-Azhar University as well. Now he's working as an assistant professor in Department of Public Health and Community Medicine, Al-Azhar University, and as an associate professor in Health Education and Promotion Department, Faculty of Public Health, Health Informatics, Al-Qura University in Mecca. He has undergone various training and certification and attended several workshops, seminars, and conferences in his professional career. Without further delay, the mic for you, or the floor for you, Dr. Muhammad. Fadl.
Assalamu alaikum wa rahmatullah. I'm Dr. Muhammad Usama Noor, Associate Professor at the Department of Health Education and Promotion, Faculty of Public Health and Health Informatics from Al-Qura University. My talk today about health education and diabetes. What is the role of diabetes educator? First, no conflict of interest regarding the material presented here, and no funding support for this presentation. And all information presented here from other sources can be found on PubMed, UpToDate, and Saudi Ministry of Health. This presentation will cover the following items: introduction, importance of health education, advances in diabetes care and knowledge, diabetes-related misconceptions, when to see a doctor, pre-diabetes, prevention of type 2 diabetes, tips for lifestyle modification, living healthy with diabetes, and finally, health education for children with type 1 diabetes. At first, we can say that health education is a gate to improve the quality of life in patients with diabetes, who will need continuous health education to achieve healthy lifestyle to improve their quality of life. what is the importance of health education? No doubt that health education and lifestyle modifications can minimize the risk of many chronic diseases, including diabetes, and reduce the burden of morbidity and mortality. Also, good health education, health promotion, and access to professional care is essential to improve the quality of life for persons with diabetes. In addition, health education and also health promotion important not only for those known to have diabetes, but also for all those who are at risk. And diabetes and its complications can be prevented or delayed by modifying the risk factors. The advances in diabetes care and the knowledge is wide-ranging, and it may include, but not limited to, check Owen blood glucose at home, different formulations of insulin, different delivery systems, diabetic clinics and care center that present in health centers and hospitals and primary health care units. Share the care of patient with diabetes by health practitioner, general health practitioners. There is some diabetes-related misconceptions that should be determined and stressed on by the health educator when taking with diabetic patient and their families. These misconceptions may include: number one, managing type 1 diabetes with lifestyle changes and a healthy diet alone. As a health educator, you should inform the person with type 1 diabetes that they will never or they will need to take insulin for the rest of their life. Number two, gestational diabetes is a temporary condition that occurs during pregnancy and it doesn't develop into a chronic condition later on. Also, as a health educator, you should inform the pregnant mother that gestational diabetes is a risk factor for type 2 diabetes. Number three, type 1 diabetes can be prevented. In fact, several studies have been conducted on prevention of type 1 diabetes, but they failed to prevent it. Number four, regular follow-ups are not required if blood sugar levels are stable. Also, as a health educator, you should inform all patients with diabetes that they should undergo routine follow-up examinations to monitor their blood pressure, cardiac condition, nervous system, eyes, kidneys, and average blood sugar levels. Number five, no need to frequently measure the blood sugar at home. In fact, studies have shown that frequent measurements of blood sugar will help a diabetic patient to become more efficient in controlling their blood sugar levels and therefore limiting the risk of developing complications related to diabetes. Number six, diabetes prevents the patient from leading a normal life. Actually, diabetes doesn't prevent a person from leading a normal life. It can be controlled and the patient can live a healthy and happy life. Number seven, type 2 diabetes doesn't need insulin treatment. As a health educator, you should inform the patient that in some conditions, especially with dangerous high blood sugar levels, hyperglycemia, the doctor may find it necessary for type 2 diabetic patient to start insulin immediately. So the decision with the physician. Number eight, child obesity is not harmful. In fact, studies have shown that unfortunately, obese children are more likely to get diabetes. Number 9, brown sugar is healthier than white sugar. In fact, brown sugar doesn't have less calories than white sugar, nearly the same. Number 10, sugar-free products are not harmful to diabetes. These products may contain sugar, okay. However, they may contain large amounts of fats and carbohydrates. Now, as a diabetic patient went to see a doctor, the health educator should inform the patient that in certain conditions and certain circumstances, they have to visit the doctor. For example, if the blood sugar is higher than 250 milligram per deciliter, despite taking additional insulin doses during illness. Or if the blood sugar is higher than 240 milligram per deciliter before meals, despite taking diabetes medication, and also if it lasts for more than 24 hours. If patients show symptoms of ketoacidosis, dehydration, or other serious complications. If fever lasts for more than 2 days without improvement. If the patient has vomiting, abdominal pain, or diarrhea for more than 6 hours. If the patient has moderate to large amounts of ketones in their urine. Also, if the patient is confused what to do in order to take care of themselves during illness. Now, what about pre-diabetes? It is a health condition where the blood sugar levels are higher than normal, but still not high enough to be diagnosed as diabetes. For example, when fasting blood sugar between 100 and 125, 2 hours postprandial between 140 to 199, glycated hemoglobin between 5.7 to 6.4. Sure, early detection and treatment of pre-diabetic conditions can help to restore blood sugar levels back to normal and prevent type 2 diabetes. Prevention of type 2 diabetes. Now, what is your advice as a health educator for prevention of type 2 diabetes? For example, annual diabetes checkup for anyone older than 45 years. Also, avoid sedentary lifestyle as laziness, long sitting hours, and inactivity are risk factors for diabetes. If you have a positive family history of diabetes, then it is essential to take care and take all necessary precautions to prevent the disease. Also, try to prevent associated chronic conditions such as hypertension, high cholesterol level, and heart disease. Tips for lifestyle modification. The health educator can help the patient to modify their lifestyle to prevent type 2 diabetes. We need some advices, such as start gradually, as adopting a healthy lifestyle will not happen overnight. Daily routine. Try to incorporate physical activity and choosing healthy food into your daily routine. And try to carry a small notebook with you at all times and write down everything you eat during the day. It will help to reduce unhealthy eating habits. Be more active. For example, take stairs instead of elevator, walking for 30 minutes per day, 5 days a week, park your car further away from the place and walk the remaining distance. Nutritional habits. Advice may include use grilling and steaming instead of frying. Eat low-fat food. It can be healthy, delicious if prepared correctly. Read try to read the nutrition fact label before buying any product to decide if it's suitable for you or not. Try to eat salad as a daily routine. We know it is healthy, delicious, and diverse. Also, don't make feasts as your preferred weekly tradition, and try to use small dishes that gradually help to eat less amounts of food without feeling hungry. Also, don't risk your health over a food challenge with your friends. Try to avoid the habit of snacking before the main meal, and don't say that I will just have one bite. Don't eat while watching series, and don't read series to be your only marathon. Don't eat ice cream or sweets when you are happy, nervous, sad, upset, moody. Also, yes, try to escape the way to the refrigerator, especially at night. Weight loss, it can lower the risk for developing type 2 diabetes. Also, try to share your plans of healthy lifestyle with your family, with your friends, or with interested people. It will help adopting the new style. Now, living healthy with diabetes, is it possible? Is it possible to live healthy with diabetes? The health educator should inform and educate the diabetic patient that it is possible to live healthy with diabetes without suffering its serious complications, whether short-term complications like hypoglycemia, hyperglycemia, or long-term complications that may affect many body systems and organs, kidney, heart, blood vessels, eyes, and nerves. This can be achieved by following the advice and receiving appropriate education from specialized medical team, which consists of doctor, pharmacist, nurse, dietitian, and sure health educator who possess special knowledge and skills, and their role is to help and guide and support the patient to adopt a healthy behavior and adhere to a healthy lifestyle. Also, this medical team can provide basic information about skills needed to control blood sugar level. This information may include knowledge about patient diet. In fact, being diabetic doesn't necessarily mean depriving patient of food that he loves or enjoys eating. How to choose healthy food, how to prepare food, developing a meal plan, the appropriate amounts of food, and the appropriate time to eat, all help to achieve healthy, balanced diet. In addition, it is important to the patient to understand the effects of different food choices on the blood sugar level. Knowledge about the disease and basics of self-care, such as knowing symptoms of hypoglycemia or hyperglycemia, how to control or how to deal with them, how to take care of your eyes, feet, skin, teeth, what are the warning signs of these complications. Also advice about appropriate and regular physical activity. We know that physical activity helps in weight loss, physical and mental fitness, improving blood sugar control, and decrease in insulin resistance. Also, it is important to make physical activity and physical exercise as an essential part of the daily routine. As we said, take stairs instead of the elevator, walking 30 minutes per day for 5 days a week, or parking the car away and walk the remaining distance. Also, to ensure continuity, it is important to choose the type of motor activity that appropriate to the patient lifestyle. Also, health education for the patient about the importance of daily follow-up of blood sugar. because it gives an idea to the patient of his sugar level to change what he does. Also, healthy education for diabetic patient about the importance of comprehensive periodic examination. It will help for early detection of any complications that may affect various body systems and organs, kidney, heart, blood vessels, eyes, nerves, and so on. Also, health education of family members. For example, self-care for the patient with diabetes, what are the emergency signs and how to deal with them, knowing the patient healthy diet, acquiring necessary skills, for example, for insulin injection, encouraging healthy behavior of the patient, tell him about the importance of regular monitoring of blood sugar, taking the necessary medication as advised by the doctor, and ensure cooperation with the medical team. Now, health education for children with type 1 diabetes. The health educator should discuss with both children with type 1 diabetes and their families certain items like the cause or the uncertain cause of diabetes, as there is no cause for plan, common symptoms and how to diagnose, risk associated with type 1 diabetes. Also identify fears and anxieties and wrong ideas of diabetes they may have. Also need for insulin and how insulin works, and practical skills in diabetes injection and the suitable sites for injection. Also practical skills in self-monitoring of blood glucose, information about healthy eating, advantage of physical activity, how to prevent adverse events during or after physical activity, and how to prepare a child to manage diabetes away from home. In addition, health education about acute complications like hypoglycemia and how to deal with, knowledge of late complications, including how to prevent these complications, management of type 1 diabetes during intercurrent illness, also care for feet and ensure that shoes and socks fit correctly. Also psychological support and self-confidence needed for self-management. In addition, health education about life issues such as diabetes at home, at school, traveling, sport, immunization, identification cards, and advice against smoking. Very important, contact with diabetes support groups and organizations. It is helpful. And the details of emergency telephone contact, and encourage regular visits at diabetes follow-up clinics at hospitals or primary health care units. Finally, type 1 diabetes at school. Some tips about type 1 diabetes at school. The child with type 1 diabetes at school may need to check their blood sugar levels, take insulin or other diabetic medication, eat snacks when necessary, eat lunch at a certain time, may need to have access to water and bathroom, participate in school events and activities like field trips, get treatment for hypoglycemia episode, known whom to contact for help in case of emergency. Important not to be discriminated or feeling different from other peers. And also it is important to inform school staff with emergency contact information with father, with family, and to inform the school staff with diabetes management plan. Thank you very much. I'm ready for your comments. Thanks a lot.
Thanks a lot, Dr. Muhammad, for your nice review. And as you know, colleagues, this is the role of diabetes educator. The diabetes education has a major role in diabetes management. It's not the matter of only a doctor or only a nurse. Diabetic patient needs a close follow-up, and this job is nicely attended or done by our colleagues, diabetes educators, who are really qualified and certified to follow closely or to monitor your patient. We know that maybe every 6 months or maybe sometimes more than 6 months to visit a doctor. In this long period, this is the role again of diabetes educators to monitor your patient closely so they can have an optimum glucose target. Right. I think we'll go further for the next topic, then we'll go for discussion. So the next topic is the multifactorial management of type 2 diabetes mellitus. And this topic will be presented by my colleague and my brother, Dr. Faisal Al-Malki. Dr. Faisal Al-Malki, actually he is the consultant endocrinologist. Actually, he is the head of diabetes and endocrine center at the Noor Hospital in Mecca. He is as well an internist consultant. He will give us a brief about the multifactorial management of type 2. We know that not only to target A1C in diabetes, we have many parameters to control in diabetic patient. So let's go for this nice topic. Floor for you, Dr. Faisal.
واضح عندكم مادة البندر؟
Sharing, yes, standard of medical care. تمام.
Okay, thank you, Mr. Chairman, Dr. Bandar. As you know, the optimal approach to type 2 diabetes management should focus on aggressive management of standard cardiovascular risk factors rather than purely intensive glycemic control. I mean, multiple cardiovascular risk factors should be considered in the management of type 2 diabetes, including, in addition to glucose control, blood pressure, lowering LDL cholesterol, smoking cessation, and weight reduction. The aim is cardiovascular disease reduction, as well as cardiovascular disease is the most common cause of mortality in people with diabetes. So, close link between diabetes and cardiovascular disease. Having diabetes means more likely to develop heart disease at younger age than people without diabetes. With reduced life expectancy, 60 years old patients with diabetes and cardiovascular disease die with average 12 years earlier, whereas people with diabetes die earlier than by 6 years earlier than people without diabetes or cardiovascular disease. So diabetes is a killer disease, and unfortunately, despite development of prevention and treatment for this disease, still 50% of people with type 2 diabetes die from cardiovascular disease. Usually associated chronic disease as cardiovascular, chronic kidney disease, heart failure present a significant challenge to global health policies and also more profound burden to health economic status. So the message is reducing the risk of premature cardiovascular death is a management priority for patients with type 2 diabetes. By the way, that means type 2 diabetes is a cardiovascular risk factors that determine the need for cardioprotection. So people with diabetes has been categorized either very high risk patients or high risk patients. Patients with documented and established cardiovascular disease or diabetes and target organ damage or a major cardiovascular risk factor, I mean diabetes plus other major risk factor, or severe chronic kidney disease with estimated GFR less than 30. All of these included in category of very high risk patients. Patients with diabetes alone or moderate chronic kidney disease with estimated GFR between 30 to 59 are included in high risk group. So diabetes either high risk or very high risk, and in some class reach extreme high risk individuals. Here, estimated 50% of individuals with type 2 diabetes have chronic kidney disease. In addition, worsening in kidney disease is associated with high mortality. You see here clear different stage of chronic kidney disease, starting with albuminuria, estimated GFR, together albuminuria and estimated GFR less than 60 ml, plotted in x-axis, is the incidence of mortality, 10 years cumulative incidence of mortality. In y-axis, we see direct relationship between the incidence of mortality and the progression of chronic kidney disease. For example, people with type 2 diabetes alone, the mortality rate 4%, whereas you see type 2 diabetes with albuminuria and estimated GFR less than or equal to 60, 10-fold more in the incidence of 10 years to reach 47%. Additionally, it is well documented that chronic kidney disease patients have extremely high risk of developing cardiovascular disease. So we have cardiovascular disease, we have chronic kidney disease associated with our major disease, which is diabetes. Recommendations were added for the use of medications have proven beneficial effect on cardiovascular outcomes is number one, and protective effect on chronic kidney disease outcome. So this the shift, I mean, in a major paradigm into broader strategy beyond glucose control. So it is appropriate now in the guidelines to treat the patients with diabetes and established cardiovascular disease with the agent reducing the risk of cardiovascular disease and cardiovascular associated mortality and the progression in kidney disease, which includes glucagon-like peptide receptor agonist and sodium glucose cotransporter 2 inhibitors. And you can prefer the SGLT2. I will not go in details, but you can prefer this group in chronic kidney disease to reduce the progression of chronic kidney disease, as I mentioned in the previous slide. These reports and others have triggered the path into researches and several cardiovascular outcome trials in recent years. and also improve subspecialties in internal medicine, communications, between diabetologists, cardiologists, and nephrologists. And it's clear to all of them is a need to incorporate to management the patient with type 2 diabetes, minimizing the end organ damage. Cardiovascular disease, chronic kidney disease, and others. In this slide, just to enumerate some trials, including in this group like Impaired, to include Impaired glycogen, Canvas program for canagliflozin, other group for liraglutide leader trial, as all of you is oriented about this. On the other hand, our presentation here, people with type 2 diabetes more likely to have other associated cardiovascular risk factors, such as high blood pressure, high LDL cholesterol, smoking, weight gain. So the message also here is not enough to reach the euglycemia in type 2 diabetes. The great physician treats the patient who has the disease, not the disease itself alone. So we have to modify the risk factors. We have to prevent their development from beginning, and this mainstay in the strategy of evidence-based recommendations and guidelines, as in American Association of Clinical Endocrinologists. Number one, and the first one is hypertension. This algorithm for treatment of confirmed hypertension in people with diabetes, if initial blood pressure greater than 140 above 90, but less than 160 over 100, you can start by one agent. If albuminuria there, consider ACE inhibitor or ARBs, even for all people with diabetes and confirmed hypertension. Think to use the agent to reduce and delay the progression from a stage to another stage in chronic kidney disease. Is along with lifestyle management. But if blood pressure from initial was 160 greater than 160 over 100, think about two agents to control blood pressure. How about the targets? For patients with diabetes and hypertension, the target should be individualized. If high risk for cardiovascular risk, you can think about the blood pressure less than 130 over 80 on treatment. If the individual with diabetes and hypertension at low risk for cardiovascular disease, think about the target of less than 140 over 90. Second point is dyslipidemia, which is common practice and updated debates on lipid management recommendations. And this table shows us the definition of risk categories and treatment goals. I mentioned before, this category, extreme risk, very high risk, high risk. The people with diabetes included in these three groups. If diabetes alone, we have to think about high risk, and the target is 100. Less very high risk, patient with established clinical atherosclerotic cardiovascular disease, or diabetes with more than one major risk factors, which are advanced age, elevated non-HDL, elevated LDL, low HDL, hypertension, chronic kidney disease, cigarette smoking, family history of atherosclerotic cardiovascular disease. If the patients with type 2 diabetes have progressive atherosclerotic cardiovascular disease, including unstable angina, think about extreme risk, and the target in some schools recommended to be less than 55. Other between 70 to 100, for people's diabetes alone less than 100. How about ADA? American Diabetes Association has mentioned Ldl treatment recommendations as a part of a standard of medical care in diabetes. And using LDL baseline to estimate the expected clinical benefits of low density lipoprotein lowering therapies, including the statin, to reach 30% average LDL reduction, plus ezetimibe less than or around 65. For the new agent PCSK inhibitors, to reach, in addition to statin, up to 80%. The third issue is antiplatelet therapy. Most important, the last line, aspirin therapy may be considered as primary prevention strategy in those with diabetes who are at risk of cardiovascular diseases. And important to balance between the risk of bleeding and the benefit of aspirin to reduce the risk of cardiovascular disease. Lastly, there is a harmony between type 2 diabetes and obesity. So, when choosing glucose-lowering medications for patients with type 2 diabetes, we have to think about the medication's effect on weight. And whenever possible, to minimize the medications, whatever the purpose for medications that are associated with weight gain, to avoid them. And remember, metabolic surgery should be recommended for type 2 diabetes with BMI greater than 40. In adults also with BMI between 35 up to 40 who do not achieve durable weight loss and improvement in comorbidities. And also should be considered a list between 30 to 35. Also, this as a consideration if the patient also not have any improvement in comorbidities related to obesity, including hyperglycemia. Coming to conclusion, recent outcomes trials have revealed that some glucose-lowering agents has beneficial effect on cardiovascular outcomes, and at the same time protective effects on kidney outcomes, and this is important for our patients. Global clinical guidelines and recommendations, remember, is a change now for patients with diabetes and cardiovascular disease. And updated, we have to update the guidelines in our practice from recent outcomes trial. To date, empagliflozin, Cana, GDABA, liraglutide, injectable semaglutide, and dulaglutide, updated FDA and European labels incorporating evidence from recent outcomes trials. And we reach the end of our presentation today. Thank you so much.
Thanks, Dr. Faisal, for your nice presentation and for your nice summary. I think now the time for discussion, so may I ask the eminent speakers, Dr. Khalid, Dr. Muhammad Noor, Dr. Faisal, to be ready for the discussion. So please, the audience, if you have any question or any comment or any query, you may raise your hand or you may write your questions in the chat box. Meanwhile, while we are waiting for your comment or your question, may I ask Dr. Khalid about the this technologies available in applications. What is the role, Dr. Khalid, of the language? I mean, these applications is in two sides. It should be manipulated or to be used by the doctor and by the patient. So I think to be simple or to be simplified in Arabic language for our patients it has a major role. So can you comment on that, please?
Yes, thank you, Dr. Bandar. The current available application is in English, but of course it can be translated into Arabic. Yes, I think this is a very important and valid point. Of course, to be able to contact your patients and talk to them, you have to use some Arabic, the Arabic language or the local language you have, especially if you are talking to patients in rural areas, of course, you know. But the current one is in English, and the one we're going to use maybe for training, inshallah, next week is in English. We don't have this Arabic now, but I'm sure it can be available also. It will not be a problem. You know, most of the applications now can be translated to different.
Okay, fine. Let us see. I think still we have no questions in the chat box. طيب. Dr. Muhammad, if you are around, please, Dr. Muhammad Noor. I think the COVID era gave us something it was negligible before, which is how to deal with remote patients or how to deal virtually with the patient. And in diabetes education as well, as the role of diabetes educator to follow the patient remotely through whatever application, for example, WhatsApp or Zoom or whatever it is, it has a good implementation. What do you think, Dr. Muhammad?
Yes, I think contact with the new devices and the new appliances, either through WhatsApp or Instagram or any similar technique after the era of COVID-19 is now must. And in our colleague and in our department, we tried to make something similar by contacting our student, the small health educator, through the university site, through the Blackboard system, and I think the same can be delivered to the patient. The face-to-face contact, I think, is now diminishing throughout the world. It will not stop, but the era of COVID-19 put us in this critical situation, how to deliver the health education message and without losing your patient or without losing interest of your patient to receive what you are saying. It is a challenge, in fact, and I think we should think more how to attract our patient through the devices and WhatsApp and similar wireless connections or remote connections. In our department and in our colleague, we success in contacting our student, and I think with patient also we will success.
Okay.
What do you think?
Agree totally. I think the COVID-19 pandemic gives us a lot of lessons. One of these lessons, how to deal virtually or remotely, even with the lectures, or even with the scientific meetings. As you see now, we are together remotely instead of gathering together. I think face-to-face has its rule, no way or no doubt about it. But sometimes it is difficult to be every time face-to-face. So we have an alternative option, either in the scientific way or in the teaching way, or even in following our patients or teaching them. طيب. I think still we have no questions. I think for Dr. Faisal, I will give the last comment, or I need his last comment. Dr. Faisal, nowadays we have many guidelines, sometimes from American approach, we have British school, we have European guidelines. We cannot say that one of them is wrong, one of them is right. All of them definitely they have their own way, correct way and researches. But the issue, how to implement in the clinical practice, when to choose, for example, European guidelines, when to use, for example, ADA guidelines, American Endocrine Association guidelines, how to implement it clinically.
You know, the issue, Dr. Bandar, and this guidelines, sometimes they mention the target LDL, for example, 55. Who patient will get the target of 55?
Yes.
And many patients will start on, for example, atorvastatin 20 milligrams. They came with myopathy the next week or after 2 weeks. So I think the manipulation depends on the clinical judgment. If you have elderly patients and this patient, for example, risky for cardiovascular disease, already established cardiovascular disease, I will think about American, for example, American College of Cardiologists. They mentioned 70 is enough to intensify, but European now they mentioned 55. But for me, I didn't see patient with 55 until now. I don't know about Dr. Khalid and other speakers here. It's difficult to depend on the LDL target. I think the clinical judgment is most important. If the patient has risk for cardiovascular disease, different for the patient only diabetes and uncontrolled blood pressure. So different scores, you are right, starting from ADA and American College of Cardiology, American Association of Clinical Endocrinologists, and then now finished with European Society. They mentioned extreme high risk with progressive. So depend on the clinical case if you have in the clinic. I didn't know there is a guidelines now practiced in our clinic, just American Diabetes is simple to mention the risk and the targets. That's it.
Thanks, Dr. Faisal. So the message for the audience, individualization is very important. Not every patient like the others. You are the one who have the clinical decision between you and your patient. All the guidelines are available. Choose the correct guidelines for your correct patient. I think if we have no comment from the speakers and from the audience, we will conclude the second session, and hopefully to see you in the third session afternoon 1 p.m. Please, Dr. Khalid, correct me.
Yes, if you allow me, Dr. Bandar, thank you, Dr. Faisal and Dr. Muhammad. It was nice presentations. You have honored us today. Thank you, Dr. Bandar. One request maybe to Dr. Faisal and Dr. Bandar or Dr. Hamid is here. If you are interested, if you can assign one nurse or a doctor for training next week on the use of artificial intelligence, we will be happy to train them. Next week, inshallah, I will tell you the exact timing. I'm trying to set a time, inshallah, during next week. So I would really think it would be nice to have one person from the Diabetes Center in Noor and another one from Hira to join us in the training. Either a nurse or a doctor, anybody, a dietitian, whoever you want to train. But English will be the language for training. This is one thing. The other thing, we will start, inshallah, immediately after Salah. So that would be around 12:30 or maximum 12:40. So we will have, because we have, alhamdulillah, good time to have a break and do the prayers. So inshallah, we'll start by 12:30 or maximum 12:40. Try to finish early. Thank you very much, and see you inshallah in the third session. And I hope that the other speakers stays with us, because we will have something like a discussion for all the speakers, how to really improve the access to care for people in Mecca. If you have time, please join us. So inshallah, see you at 12:30 after Salah. Thank you very much.
السلام عليكم. الو 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 الو
السلام عليكم ورحمة الله. طيب الحمد لله we are on time. إن شاء الله تكونوا الجميع أتمكن من أداء الصلاة. We will start our third session, and because Dr. Humayd Al-Sahafi, he apologized for being chairman for this session. He had a commitment that he had to leave. So I'll be sharing this session, inshallah. And we should have 4 speakers, but because I did already my presentation, so we'll have 3 speakers in this session. We'll have Dr. Nasir Jahani, then Dr. Bandar, and lastly we will have Dr. Badi Al-Anazi. Then we'll have a discussion, and we will have a sort of discussion with all speakers before we end this session, to see how we can help improve access to care. So this is the subject of the International Diabetes Federation for this year, is access to care, how we improve patients to care. So without further delay, I would like to introduce our colleague, Dr. Nasser. Dr. Nasser actually is not only a speaker, he was helping us in the organization. He was trying to guide us. So thank you, Dr. Nasser, for that. Dr. Nasser carries an FRCP from UK, and he's a consultant internist and endocrinologist, the head of the medical department in East Jeddah Hospital. And of course, he is a member of the Saudi Scientific Diabetes Association, and he's very active actually in the area of diabetes care. So it's my honor to introduce Dr. Nasser, who will talk to us about insulin therapy. So please, Dr.
Assalamu alaikum. Thank you, Dr. Khalid Tayyib, for this nice introduction. I thanks all the audience. Please, can share the screen? Can I share the screen? Stop sharing from your side. Can I share? Or can I stop sharing?
You're not able to share this?
Okay, let me to see now. Okay. Is it clear now or not clear?
Yeah, we have it.
Is it clear, huh?
Yeah, it is.
Thank you very much for you, Dr. Khalid, for this nice introduction. Today, I will talk about update in the insulin therapy. I have disclosed none for this presentation. This is the outline of the presentation. Recent insulin analogs, ultra-fast acting insulin, ultra-long weekly basal insulin, and inhaled oral insulin, and different insulin regimen in type 2 diabetes. And briefly, I will talk about the ADA guidelines regarding the insulin and then conclusion. As we know, insulin is life-saving in type 1. Type 1 patient, they cannot live without insulin. Usually, actually, they die before the discovery of insulin 100 years ago. So it is needed for survival in type 1. In type 2, to control blood glucose and prevent complication. It is the most effective insulin. It is the most effective lowering agent. Adding second oral agent or GLP-1 to initial monotherapy in type 2 diabetes generally lower hemoglobin A1C by 1 to 1.5. So really we need a potent drug that has no dose limitation. The limiting dose for insulin therapy only is the hypoglycemia. Most patients with the progression, as we know, type 2 diabetes is a progressive disease. So most of the patients, ultimately, they will need insulin therapy. If you can see from this, the reduction of hemoglobin A1C, okay, in the x-axis and the drugs in the, the reduction of hemoglobin A1C in the y-axis and the drug in the x-axis, you can see here, insulin is the most potent drug. So probably basal bolus insulin will reduce hemoglobin A1C by more than 2.5. If you see the other drugs, oral agents, in average, they reduce hemoglobin A1C by 1 to 1.5. The other thing, in the United Kingdom prospective diabetes study that they look for type 2 diabetes, okay, they look for them, they found that at 6 years, almost 50% of the patient with type 2 diabetes at that time only available sulfonylurea and metformin and diet. So at 6 years from the diagnosis, actually they need insulin. So this is indicate that type 2 diabetes is a progressive disease despite of diet and increasing physical activity and multiple medications. This is the normal insulin secretion. We have basal insulin secretion. This is suppress blood glucose in the night, okay, and while we are asleep and between the meals. And we have bolus insulin. This is limits the hyperglycemia after the meals. What are the targets? The target for most of the patient is below 7, 6.5, probably in some patients, short duration diabetes, patient in no medication or only taking metformin, and they have no cardiovascular risk disease, we can go below 6.5. This is according to the American Diabetes Association. But if you go to other guidelines like ACE, American Association of Clinical Endocrinologists, may from the start, they start below 6.5. Sometimes we keep hemoglobin A1C higher, like patient with advanced complication, patient with renal failure, heart failure, okay, advanced complication like retinopathy, renal failure, severe hypoglycemia, an elderly patient, limited life expectancy. We expect that the life of the patient will live less than 5 years. For example, patient with major organ dysfunction or patient with cancer will not go for tight control with this patient. We'll keep hemoglobin A1C around 8. So which insulin to start? We have different insulin regimen. We can have basal plus oral agent. We can have a premixed insulin, okay, or basal bolus insulin, or GLP receptor agonist plus basal insulin or bolus insulin. So the basal insulin usually is the easiest to use. If the hemoglobin A1C below 9, okay, we can start it. It is very simple, 1 injection per day, better compliance, simple titration. The main problem with it, at 1 year, 70% of the patient, they will need bolus insulin. So if you start basal insulin, most likely at 1 year, you will need, okay, a bolus insulin. You can start any insulin, larger 100, 300 decimal diglycolic. Okay, usually you start 10 units at that bedtime, but you can do it in the morning, no problem. Usually you keep the medication, DPP-4 inhibitors, selective glucose transporter inhibitors. Usually, if there is hypoglycemia, you may reduce the sulfonylurea. Usually, we ask the patient by himself or herself to adjust the dose by 2 units every 3 days to keep the blood glucose from 80 to 130. If the blood glucose drop less than 80, they reduce the dose next day. If there is no explainable factor, they reduce it by 20%. Sometimes, as we said, basal insulin is not enough to control blood glucose. And if you control fasting, usually basal will control fasting, and hemoglobin A1C still high, this is indicate that there is postprandial hyperglycemia, or if the patient developed nocturnal hypoglycemia, you may reduce the dose or split, or if you reach the dose of the basal insulin more than 0.5 unit per kg. At this situation, you may add, okay, bolus insulin. You will not titrate more the dose. Insulin intensification can be from basal to basal plus or basal bolus, as we know in Asian country and probably Saudi Arabia, one of them, that we have high carbohydrate content. We eat a lot of rice, we eat a lot of breads, okay? So probably there is a lot of carbohydrate. And we know that if you compare carbohydrate to lipid or to protein, the carbohydrates, the most likely will increase the blood glucose postprandial. Usually we start the bolus insulin by 4 units before the largest meal, the meal with the largest carbohydrate content, or the meal that to our postprandial more higher. Usually we'll continue basal insulin. Sometimes you may reduce it. We'll continue oral agent like metformin. Sulfonylurea will be stopped. Adjust the dose of basal insulin according to our postprandial, or you can monitor also pre-meals. So either you can do 2-hour postprandial or prandial blood glucose. And as we said, in basal insulin, you increase the dose of rapid-acting insulin. You can start with 1 meal, then you proceed to the other meal. So they adjust the dose every 3 days by increasing 2 units until 2-hour postprandial blood glucose or pre-meals blood glucose in the target. And we repeat hemoglobin A1C after 3 months. If the patient clearly or the reading high, okay, or suspect LADA, okay, in adult patient, you start basal bolus for injection per day. And usually the starting dose, if the patient accepts the injection, 0.5 unit per kg, okay. If the weight is 80 and hemoglobin A1C high, you can start 80 multiplied by 0.5, so 0.25, 20 units long acting, so 50% is long acting and 50% is rapid acting, divided equally between them. This is just a starting dose. Most of the patient, they will need more. Usually they will need 0.8 to 1 unit per kg. Basal bolus is more physiological, but the problem and allow more flexibility in milk content, lower hemoglobin A1C, improve lipid profile, but the drawback, it requires motivated patient and physician, frequent glucose monitoring. Unfortunately, patient in our society, they don't monitor blood glucose actually. They should monitor according to the number of insulin injection. If they have 2 insulin injection, they should monitor twice daily. If they have 4 injection, they should monitor 4. But unfortunately, the patient, they don't monitor blood glucose. So sometimes, okay, you need to give simple treatment or simple insulin regimen like a premixed insulin BID or TID. Sometimes like type 1, we do carbohydrate counting for them. Premixed insulin, usually if we decide to start them, we start 10 units BID, we continue metformin, DC sulfonylurea, monitor fasting and pre-dinner blood glucose. The same, we adjust the fasting and the pre-dinner by increasing 2 units every 3 days till we reach the target, 80 to 130. The main problem in the premixed insulin, because there is no flexibility in the dosing. I mean, there are 2 insulin in the same bin or 2 insulin in the same file. Meal should be in time. And it is good if the meal content of the carbohydrate is the same. So usually if meal in time and carbohydrate content is the same, will work very well. This is the advantage. Simple, both basal and single bin, can cover insulin requirement most of the day, but require consistent meal and exercise pattern. Cannot separately titrate individual insulin component. So usually we give it to patient. So this is how to choose between a premixed or basal bolus insulin. If the patient prefer fewer injections, if the patient not willing to monitor blood glucose frequently, in this time probably I will prefer a premixed regimen. If the patient has fixed meal, okay, premixed insulin. If the patient has variable meals, eat at many times, different times, better to have flexible regimen like basal bolus. If the patient has limited cognitive function, if the patient need assistance by relative, better to give them simple regimen like premixed insulin. But if the patient motivated, compliant with good cognitive function like young patients, we prefer basal bolus. And always in type 1 and the pregnancy and renal failure, we prefer basal bolus. But sometimes type 1 diabetic patients, they are non-compliant actually. Okay, so probably occasionally we can start with the premixed insulin. This is very popular now to combine GLP receptor agonist plus basal insulin. They usually reduce hemoglobin A1C depending in the baseline hemoglobin A1C by 0.5 to 1. There is low risk of hypoglycemia or there is no risk. Okay. Weight reduction 3.22. This is the different insulin regimen. This is the basal MPH, glargine 100, 300, insulin detemir, insulin degludec, the rapid acting insulin or short acting or meal insulin, regular insulin lispro, aspart, glucosamine, okay, fast acting insulin aspart, ultra rapid lispro, or premixed insulin biphasic insulin, okay, human insulin 3070, biphasic insulin aspart 3070, or biphasic insulin lispro 2575, or insulin degludec 3070. So there is available different regimen of insulin therapy. The limitation of the glargine and detemir that they are not truly peakless, they have a peak, and the duration usually of glargine and detemir less than 24 hours. Okay, which lead to lack of flexibility of dosing regimen. The other thing, because of the variability, there is risk of hypoglycemia. So the solution is second generation new basal insulin. One of them is insulin glargine 300 Toujeo, that approved in 2015, duration of action up to 30 hours. It is the same like glargine regarding hemoglobin A1C, but there is reduction of the nocturnal hypoglycemia by 20 to 30%. The other thing, there is a flexibility. For example, if Lantus or glargine 100, you give it at 9 p.m. This is, you can give it 3 hours before or 3 hours after. The other insulin is insulin degludec, longer duration. There are two types, 100 units per ml or 200. There is no difference. If the patient needs a huge amount of insulin, you can use 2 units per ml. Compared to Ditimer, similar hemoglobin A1C reduction. There is reduction of hypoglycemia and nocturnal hypoglycemia compared to Ditimer or glargine. Also, there is a flexibility of the dosing. Here they can give it 8-8, and then, for example, in the second day you can give it at the night. But usually we advise the patient to give insulin at the same time, because sometimes the patient forgets the time he take the injection. This is the indication for low volume or concentrated insulin, patient with nocturnal hypoglycemia, patient require flexibility in timing, or high basal insulin need more than 80 units per injection. You can give glargine 300 or degludec 100 or 200. Fixed combination, the latest is insulin degludec, premix insulin and aspart, dosed once or twice daily. Okay, if you compare it with Nofomix, similar efficacy, but there is a reduction of hypoglycemia overall and nocturnal. There is no difference in severe hypoglycemia. It reduces mild to moderate hypoglycemia, and really it is the most common hypoglycemia in type 2 diabetes. What's about the combination of GLP receptor agonist plus basal insulin? All they can combine, okay? There is available fixed combination like insulin degludec, liraglutide. It will decrease hemoglobin A1C by 1.9, weight reduction 2.7, lower hypoglycemia. The other combination is glargine plus lixisenatide or Siliqua. Okay, this combination is preferable if the patient failed oral agents and if hemoglobin A1C more than 10. So if the patient failed 2 oral agents or 3 oral agents and hemoglobin A1C above 10, according to the American Diabetes Guideline, you can start GLP-1 plus basal insulin. Really, I use it off-label in basal bolus insulin. Also, I use GLP receptor agonist with basal bolus insulin or with the premixed insulin for patients not controlled in insulin. We know that the insulin, short insulin analog like Lispro, they reduce postprandial hyperglycemia. The other thing, compared to human regular insulin, they reduce, okay, nocturnal or hypoglycemia by almost 36%. We have no another new insulin available. It is approved faster acting aspart, ultra rapid insulin Lispro. The fast acting aspart or Fiasip, it is FDA approved in 2017 for adults and 2020 approved for children more than 2 years. The main difference, it works immediately compared to the Lispro. This is the Lispro ultra rapid acting fast, and this is the regular Lispro or Humalog. Okay, ultra fast Lispro. Okay, start action 10 minutes almost before, and the peak is higher. So it is more physiological compared to the Lispro insulin. So the main advantage of the fast acting insulin aspart that can be administered 2 minutes or up to 20 minutes after the meal. Onset of action is earlier. There is a reduction of postprandial hyperglycemia, and we know postprandial hyperglycemia may be associated with risk of microvascular complication. Okay, it is non-inferior regarding hemoglobin A1C. It may lower post-meal hypoglycemia more than 4 hours because of the short duration. The other approved ultra rapid acting insulin that decrease postprandial hypoglycemia is Lomogef or ultra rapid insulin lispro. This is concentrated insulin. We know before 2016, human regular insulin new 500 is available in vial. Now it is available in bin. The only indication for this concentrated insulin is in severe insulin resistant patient if the dose exceeding 200, more than 200 per day. Okay, you can use it. What's about ultra long weekly basal insulin icodic? It is not yet approved. It is important advancement really. Okay, it can improve compliance and adherence to insulin therapy. And once basal insulin with nearly flat insulin profile could reduce within day glucose variability, and this could result in more consistent and predictable glycemic control. This is in New England about the study about this molecule for diabetes. If you can see here, if you compare insulin icodic, usually the glargine they start 10 units. This is they start 70 units once per week. They found them comparable regarding the reduction of hemoglobin A1C, but there is a lot of issue to be solved. For example, if hypoglycemia happen with patient in weekly insulin, what we can do? Still not solved. The other thing, the reduction of hemoglobin almost the same. There is less dose with icodic compared to glargine. So the requirement for insulin dose with icodic once weekly is less compared to glargine. The other thing, okay, there is a slight increase of the risk of hypoglycemia with insulin icodic because they use higher dose. And the other thing, they usually icodic in weekly insulin, they increase insulin dose by 21 units. But in this studies, the first study about icodic, they increase the dose by 28 units. Imagine you have combination of once weekly basal insulin and once weekly GLP-1. This is called icosema in phase 1 trial. So this is probably will improve, okay, the treatment of type 2, or the compliance of the patient if you have combination of once weekly insulin plus once weekly once weekly GLP receptor agonist. About oral insulin is still investigational. This study they use long-acting oral basal insulin versus subcutaneous. If you can see here in the blue, this is the oral basal insulin, and in the red is the glargine insulin. They have actually similar reduction, okay, in the similar reduction in blood glucose, but the main problem really they need large amount of oral, because we know that insulin is a protein and destroyed in the stomach, and it needs a carrier. So really you need almost 60-fold the higher dose with oral insulin if you compare it with the glargine. So really the company stopped the study because really require large amounts that cannot manufacture it. This is a novel oral capsule that can deploy microneedle that release drugs into the intestinal wall for uptake into the bloodstream as shown in animal studies. This is still investigational. If you can see, this is a triangle or 3 hawks. This is a tablet. We'll take a tablet, and the tablet will go and will attach, will not destroyed by the acid in the stomach. So we'll go to the small intestine, and in the small intestine, it will attach to the border of the small intestine and release the insulin slowly. But again, there is a problem with the meals, okay? There is a problem if the patient has gastroparesis, so still under investigation. What's about insulin? This is a new insulin dance, 501 inhaled insulin, still investigational. This is inhaled power. We know that Afrezza insulin is another insulin is approved in 2014. This is another insulin, it is a liquid form. They put it here and they inhale the vapors. They found it has faster onset of action, okay, compared to the insulin lispro, and there is good tolerability. There is no cough, and may become clinically meaningfully alternative to rapid acting insulin injection. It's usually given like rapid acting insulin before the 3 meals. This is intranasal glucagon powder used in severe hypoglycemia. It is expensive, cost around 500. Okay, $, it is not available, I think, in Saudi Arabia. I'm not aware of the private. It used in severe hypoglycemia only if the patient lose consciousness. So it is much easier than the insulin, the glucagon IM injection. This is the American Diabetes Association guideline. If the patient failed dual or triple therapy, you can use GLP-1 and then you add basal insulin, or use combination of GLP-1 plus basal insulin. If the patient not improved, for example, you add GLP-1, then you add basal insulin, and not improved, you can add prandial insulin, or you add more injection of prandial insulin, 2, 3, or you add premixed insulin. So probably if you add premixed insulin, BID plus GLP will increase, will increase complexity, and probably it is increase the number of the injection. So ultimately you can go to basal plus insulin. So in conclusion, insulin the most effective agent, glucose lowering only limited by hypoglycemia. Add insulin early in patients who don't meet the AC target. Most patients will eventually need insulin therapy. Thank you for you.
Thank you, Dr. Nasser. That was really an excellent update on insulin therapy. I hope you stay with us because I'm sure you'll have a lot of questions at the end of the session. Our next speaker is Dr. Bandar Damanhouri. Dr. Bandar is a consultant adult endocrinologist and diabetologist. He works in Hira Hospital in Mecca. He carries a fellowship. He's also the fellowship program director, and he is the head of the Saudi Society of Endocrinology, the Mecca chapter. A very active young physician. We hope that the best for him, inshallah, in the near future. Dr. Bandar will be talking about new modalities in diabetes management. Dr. Bandar, please.
Thanks, Dr. Khalid, for your introduction. Really, I'm happy here to be with you for in this event, and hopefully that we have something new to present for our colleague. As you mentioned, our topic today will be about the new modalities in diabetes management. We know that in diabetes field that we have every day something new about diabetes. So I tried my best to summarize the recent update in diabetes field in regard of medications, technologies, guidelines. Inshallah, it will be nice for everyone to have this review. At the beginning, I like to introduce for you the Twitter account for Saudi Society of Endocrinology, Mecca chapter, EndoDMOS. So it is in front of you. If you are interested, please follow us in this Twitter account, which is a pure scientific account in regard of new modalities or new update and some review in regard of diabetes and endocrinology. So please follow us if you are interested. So without further delay, I hope the slides are okay and my sound is okay. I will go further. As we mentioned, the field of diabetes care is rapidly changing as new research, technology, treatment that can improve the health and well-being of the people with diabetes continue to emerge. In this lecture, we'll try to focus on some of these updates. Let's talk in the beginning about oral drugs. In 2017, we have one of the new medication approved in the group of SGLT2 inhibitors under the name of ertigluflozin. It is SGLT2 inhibitors, as I mentioned, approved to be used in diabetic type 2 patient. We have two concentrations, 5 milligram and 15 milligram once daily. Under Stiglatro is the trade name. The second one is semaglutide, and this is called the game changer. Why it is called the game changer, semaglutide? Semaglutide, in the beginning, it was, we know, injection, but in 2019, it was approved by FDA to be an oral tablet. So that's why it was the first GLP-1 agonist to be introduced into the market in oral form. And inshallah, within weeks, it will be launched here in Saudi Arabia, and hope we see it soon. So we know that this group is used to treat type 2 diabetes mellitus. The dose of this drug is semaglutide 7 milligram, and usually we started by 3 milligram, and then you go for up titration into 7 or 14 milligram according to the A1C or the recommended or the target sugar for your patient. We know that this group has an effect on weight, and usually we have 3 to 4 kilogram loss while using this medication. It is again once daily to be given, and as usual, the GLP-1 side effect, GLP-1 agonist, side effect is the most common to have nausea, for example, vomiting using GLP group, and you have to make sure that the patient has no pancreatitis history of multiple endocrine neoplasia type 2. That's why maybe it is the time to ask when you are initiating this medication to ask your patient about the pancreatitis history or medullary thyroid carcinoma history. How to be given? It should be given on empty stomach with plenty of water, waiting less than 30 minutes or taking with the food, then you can take the medication. This is to give a good absorption time through the stomach. Let's go for the next one, sotagliflozin. Sotagliflozin, under the trade name of Zynquista, it was approved in 2019 by the European Medicine Agency, EMA. Actually, it has two or double action, SGLT2 and SGLT1 inhibition. According to the EMA, can be used in type 1 diabetes who have some element of overweight, in which they have body mass index or BMI more than 27. When insulin dose not achieve good glycemic control. The dose is usually 200 milligram tablet once per day before the first meal of the day. So what is the purpose of SGLT1 and SGLT2 inhibition? By blocking SGLT1 in the intestine, this drug delays the absorption of the glucose into the blood after the meal, and by blocking the SGLT2 in kidneys, this drug allowing glucose to pass out in the urine. So we have double action to have a better control in the glucose, in the blood glucose. Results from the one of the famous trial, it's called tandem trial. In this medication, sotagliflozin versus placebo, we observed that we have a reduction in A1C by about 0.25% from the starting A1C of 7.6, increased time in range by about 1.3 hours per day, lost the patient about 5 pounds if you compare it with the placebo, and decreased total daily insulin by about 4%. Just to have a review about SGLT2 inhibitors, we know that SGLT2 inhibitors, if used with the diabetic patient, EMA proposed that BMI cutoff in light of greater benefit and reduced risk of DKA. There is a risk of euglycemic DKA in patients using this medication. So it is recommended only in overweight, BMI more than 27, and obese patients. Why? They have a resistant element. But it is not approved to be given for people with no resistance. So earlier, the DKA, or sorry, the FDA did not, American FDA did not give the approval, but only European approval is there. So if you patient is started on this medication, should be instructed to check for ketones monitoring to prevent any element of TKA. Let's go for the next medication. It is under the name of Esperson impedoc acid or impedoc acid. Yes, it is under the trade name of Nexlitor. It was approved in 2020 February by FDA. What is the purpose of this medication? It is used for dyslipidemia, once daily oral drug, non-statin to target LDL cholesterol. So this is again one of the medication we hope to be seen soon in our market. Let's go now for the second category, which is the injectable therapy. The injectable therapy, again, for diabetes management, we have a group of medications. The first one is the insulin Lispro biosimilar. We know that Lispro was introduced in the market many years before, but we have a new biosimilar. It is called Admiloc. It was approved in 2017 by the FDA to be given for patients with diabetes 3 years and older. Can be given for both type 1 and type 2 patients. We know that as the rapid-acting insulin can be given as injection or pump or intravenously. This is again one of the options available. Let's go further. We have approval for the glucagon in 2019 for what is called Gvoke. What is Gvoke? Gvoke is glucagon injection, approved in 2019. It is actually a ready-to-be-used pen. It can be kept in the room temperature. It is in the formulation of stable liquid glucagon. We have 2 doses, 0.5 and 1 milligram, one for the pediatric and one for the adults. The pediatric and adult patient with diabetes more than 2 years can use this medication. It is the first glucagon product approved to be given via auto-injector or pre-filled syringe. I will show you the usual, or the one you are familiar and all of us familiar, which need preparation pen. You have a powder and you have a saline and you have to mix it before giving the injection. But this already pre-filled syringe, just open the cap and inject it immediately. In hypoglycemia or severe hypoglycemia cases, we need something rapid to be given to revive the patient. So it has, or it is easier for patient or caregiver to be administered quickly to revive the patient in hypoglycemia. How to inject or where to inject? This is the usual size to be given, either in the lower abdomen, outer thighs, or outer the upper arm. All of these are the sites to be given, or you can give your pen. This is the traditional glucagon, which is, I think, more all of us familiar with. It needs 10 steps or 8 steps for preparation before injection. You have a saline-filled syringe, remove the cap from the vial, remove needle protector from the syringe, inject liquid into the powder bottle, then mix it, draw the fluid, and then injection. Maybe 8 steps to be carried out before the injection. And in severe hypoglycemic cases, in which patient maybe he has coma, for example, or he has seizure, for example, you need something to be given more quickly. That's why maybe this Gvoke will help us in this particular scenario. Let's go further. The liraglutide, this is one of the GLP-1 agonists. It was approved for adolescents in 2019. You know, liraglutide was approved previously on all for the adults, but if you have type 2 patient in adolescent between 10 and 17 years, maybe you can use it after the approval in 2019 by the FDA. We know that in this age group, we have a limited medication to be given in adolescent. It was only metformin and insulin. And fortunately, now we have this liraglutide to be given in this particular patient. GLP-1 agonist story in 2005. It was the first one, or the first GLP-1 agonist exenatide was extracted from the lizard, and then we have many manufacturers GLP-1 agonists in the market after that. Let's go further for another approved medication. Recently is dulaglutide. We have dulaglutide many years before, but what is the new? In September 2020, FDA approved new doses. Again, it is under the name of Trulicity. The FDA approved 2 additional doses of once weekly GLP-1 agonist dulaglutide. We have 3 milligram and 4.5 milligram doses. This is the family of Trulicity. If you remember, already many years we have 0.75 and 1.5 Trulicity, and now once weekly 3 and 4 milligram Trulicity is available. How to up titrate? According to your A1C, according to your sugar target in your particular patient. So if glycemic control not achieved, you go further with the insulin, with the Trulicity dose. Next medication is the exenatide extended release. What is the new again? This is available in the market since before, but in 2021, for patients with 10 years and above, with type 2 patients, diabetes mellitus, it is approved to be used. It is once weekly injection under, again, of the GLP-1 agonist group. It is called Bideron. It is a pre-filled single dose auto-injector medication. So one of the options available in this year for the type 2 diabetes mellitus in adolescent age group is this exenatide once weekly. Baqsimi, what is Baqsimi? Baqsimi, again, it is a glucagon. It is the 3 milligram glucagon approved in 2019 by the FDA. Actually, it is, as you know, glucagon, it means to correct the hypoglycemia. But what is new here? It is intranasal, can be given intranasally, one nostril into single nostril. If no response, can be given after 15 minutes with new intranasal device. So it is used again for hypoglycemic patient or to correct hypoglycemia in diabetic patient. What is the age of approval? It is approved for 4 years and older. So again, hope to see this soon in our market or in our area. Now I am moving to the technologies. So what is new in technologies? I think we have much more devices, much more technologies in the recent years. One of the approved devices is the, what we call it, FDA authorized, the first interoperable automated insulin dosing controller. Actually, it was approved in December 2019, tandem diabetes care control technology. It is actually an interoperable automated glycemic controller device that automatically adjusts insulin delivery to the person in operation room with diabetes by connecting to alternate controller enabled insulin pump and integrated continuous glucose monitoring. You know that now in the operation room, either to use insulin infusion with dextrose in another line, or we use the old-fashioned, which is GIK, for example, bottle of glucose with insulin and potassium. But with this new technology, we have continuous glucose monitoring can be attached to the patient, and in another side you have this insulin controller, and ultimately there is a connection between these two to go and up and down with the insulin doses delivered to the patient. I think this is the last category, diabetes medication under development. In addition to these new medication in the recent years, still we have currently some medication under development. One of them is icodec icodic is once weekly insulin icodic. We reached phase 3 investigation by the Novo Nordisk, and actually their proposal to be given for both type 1 and type 2. It should be comparable efficacy and safe to once daily insulin glargine 100 in phase 2. So hope to see this soon, inshallah. It will give a huge difference in the clinical practice and in both sides, for patient or caregiver side and patient side, for the compliance issue. طيب, take home message: diabetes is not the end of the story. A big hope is there, especially with the new drugs, technologies, etc. In diabetes field, knowledge changes quickly, so expect to have more and more and try to be updated. Finally, I thank all of you, and I like to remind you about our Twitter account, IndoDMOS, which is again a scientific account if you are interested. So please follow us. Thank you.
Thank you, Dr. Vander. Again, that was really an excellent review of the present and maybe the future modalities in treatment of diabetes. Our last speaker is Dr. Vander Al-Anazi. Dr. Badi Al-Anazi. Dr. Badi is a pediatric endocrinologist and diabetologist. He is a consultant at Imam Hospital in Riyadh, and he is the head of the diabetes unit. He is also an assistant professor at Al-Marafa University.
At Al-Ma'rifa.
Al-Ma'rifa, sorry. It's written in English, so I couldn't realize. So Dr. Vander will talk to us about update on type 1 management of diabetes. Dr. Badi, please.
Assalamu alaikum. Thank you, Dr. Khalid, for invitation. My topic today will be update in management of type 1 diabetes, especially in children, as I am a pediatrician. This is the objective. We'll talk about the challenges in diabetes type 1 and the past, present, and the future of management of type 1 diabetes. We'll talk about the medication to delay the progress of diabetes. We'll talk about the hemoglobin A1C. We'll talk about also the time to range and the conventional management and the intensive management. Also, we'll talk about the CGM, insulin pump, and carb count. So this is the classical presentation of diabetes type 1. There is 2 weeks before school and pre-pubertal. And the symptom usually is polyuria, polydipsia, recent weight loss. 40% of children, they will present with DKA, and a good percent of those patients, they will have honeymoon period. And as you know, 95% of patients, they will have a positive antibodies, autoantibodies. However, 5% of them, they will not have the positive antibodies, and 5% will have first or second degree relative to the same disease. So what is the challenging in diabetes type 1? So there is now a phase 2 study. It's a randomized double-blinded trial of teplizumab, which is anti-CD3 antibody. It was given to the relative of diabetes type 1 who is at risk of progressing to diabetes. And they found that the age of diagnosis in the placebo group was 24 months, while in the group of anti-CD3 antibodies, teplizumab group, the onset of diabetes was 48 months. So the conclusion was teplizumab was delay the progress of diabetes type 1 in the high risk group for about 2 years. This is, as you know, the well-known study, diabetes control and complication trial, that is correlating between the high hemoglobin A1C and microvascular complications. If you have high hemoglobin A1C, you will have more likely to get the complication earlier. Okay, but there is some limitation of hemoglobin A1C. As you know, hemoglobin A1C provides the average blood glucose over the last 2 to 3 months, but does not detect hypoglycemia or hyperglycemia on daily basis, and it is not reliable measure in patients with anemia, hemoglobinopathies, iron deficiency anemia, or during pregnancy, and does not reflect the rapid change in daily glucose control. So there is many limitation of using hemoglobin A1C. As you know, the emerging target now is time in range. So time in range now in the most or all of the CGM device is considered now as the new hemoglobin A1C. In my daily clinic, I inform my patients to look to the time in range. And each visit, I will ask the patient, what is your time in range? Now, most of my patients, this is my experience in my patients, most of them, they will know what is my time in range and what is the target in the next clinic. And I find it very useful to educate your patient about the time in range. As you know, in the diabetic control and complication trial, the conventional therapy and intensive therapy, when you compare the intensive therapy to the conventional therapy, you will find, of course, hemoglobin A1C is better in the intensive therapy. And we are using in pediatric, most of the children, we are using the intensive therapy. So insulin in diabetes in children, the dose usually is 0.5, especially in the newly diagnosed patients without DKA. But if the patient have DKA, most of the time we will use 1 unit per kg per day. Why? Because in DKA, the patient will have absolute insulin deficiency. Then we can adjust the dose by 10 to 15%. And the diabetes in children management depends on the education of the family, control of the symptom, prevention of acute and chronic complication, meal plan, exercise, and blood glucose monitoring. So this is the conventional treatment for the last 20 or 30 years. We are using the conventional treatment, which is using 2 doses of insulin, 2/3 of the dose in the morning and 1/3 in the evening, usually 2 types of insulin. Most of the time we are using MBH and regular. So 2/3 of the dose will be intermediate, most likely MBH, and the third will be regular. This regimen, the MBH and regular insulin, it is good regimen, but however, it is not flexible. So the patient has to take the dose on fixed time every day. And the patient has to take the food after that. So it is not flexible with the patient condition. However, now the intensive therapy, basal bolus therapy, or multiple daily injection, you will give half of the total daily dose as a basal and half of the total daily dose as a bolus, divided into the 3 meals and cover the carb count according to the carb count. So the intensive therapy or multiple daily injection is similar to the way of insulin secretion. Insulin normally secreted in the body in 2 forms: basal all the day and bolus after meal. So the intensive therapy is trying to mimic the physiological insulin secretion. So we found that patients on multiple daily injection, they will have better hemoglobin A1C. However, because there is 4 injection daily, some family, they will refuse multiple daily injection and prefer 2 doses of insulin daily, like the conventional women, MBH and regular. As you know, this is the technology on diabetes. My colleague talked about the device of CGM. As you can see here, some glucose reading, and you can see here the glucose reading. Most of the reading here it is in the normal range. One reading is in the it is high. While with CGM, the same patient, you can see there is great variability of the blood sugar all the day. And this is the beauty of CGM. The CGM detects the variability of glucose. This is the some of the FDA approved CGM system. We will not talk about detail about this device, but as you know, it's the Dexcom Abbott Freestyle Libre. This is the one available here, and also the Medtronic Guardian CGM. Regarding the Freestyle, it is approved in 2017. It is factory calibrated, so no need for finger stick blood glucose calibration. 10 to 14 days wear, and measure glucose every minute and record reading every 15 minutes. And display most recent 8 hours of that. Patient has to take the data, has to take the blood sugar within 8 hours. So has to take the recent 8 hours of glucose reading. And no arrows, there is arrows and there is no alarm. However, the new version of Freestyle Libre, there is alarm, which is the phase 3. And the last one is mean absolute relative difference, which is to compare the CGM. It is 9.7. If the percent is high, this is indicate that CGM is not accurate, and if the percent is low, that indicates the device is more accurate. And this is Dexcom also, and also we have Medtronic Guardian. As you can see, the mean absolute relative difference is almost the same. So there is no significant difference between the 3 devices, Freestyle Libre and Dexcom and Guardian. So we'll talk about the insulin pump. As you know, there is many company with the pump. Most common is Medtronic. There is some reason to discontinue the pump. Some patients, they will not, especially children, they will not prefer to use the pump because of wearability, issue with wearability, or problem in glycemic control problem, or they don't feel that the pump is helpful, because some patients, they think that the pump, it will solve all the problem, and you know, this is not accurate. Or they feel that the pump is complicated for them, or the cost of the pump, or there is no support from the family. So this is some reason why some patients, they don't prefer the insulin pump, and they prefer the insulin injection. So you know, the insulin pump, the total daily dose, it's divided into 50% basal rate and 50% bolus. The bolus depends on the carb count and correction dose, and the basal is divided by 24 hours and start with 1 basal rate. For example, if the total daily dose is 12 units divided by 24 hours, the basal rate will be 0.5 units per hour. While the bolus, it depends on the carb ratio. How to calculate the carb ratio? You divide 450 divided by total daily dose, and you will have the carbohydrate ratio. And sensitivity factor, you divide 1,700 divided by total daily dose. It will give you the insulin sensitivity. This is the one for correction of insulin dose. So we encourage all the family of diabetic children for carb count, and to look for the carb count by serving, by weight, using a book. There is some application. And we noticed that if the family, they are educated about the carb count, the patient will be better controlled in hemoglobin A1C. So if the pump used correctly, hemoglobin A1C will be better, less frequent hypoglycemia, and better quality of life, more flexible daily schedule of meal and exercise. You know, the pump is excellent for the patient's lifestyle. Even in unit, they can use insulin pump. So this is some recent FDA approved medication and technology. The nasal glucagon, it is ready to use nasal formulation, simple, and success rate is 95%. And given less than 30 seconds in emergency, it is very simple, and the patient have confidence with using nasal glucagon more than the injection. You know, the injection needs preparation, as mentioned by Dr. Banda. Also, there is a faster aspart insulin, which is PS. This is faster than the aspart insulin, can be given freely. And also the FDA expand the use of Toujeo on children with diabetes up to 6 years. So now children with 6 years age, we can use the Toujeo. By this, I reach to the end of my presentation. Thank you all. Thank you, Dr. Khalid.
Thank you, Dr. Bhatti. Again, that was a very good update on the management of type 1 diabetes, especially on insulin therapy and the use of pumps and other devices to control patients with type 1 diabetes. I will open now the floor for discussion, or if you got any comments or questions, please raise your hand so that I can see that. Okay, meanwhile, I would like to ask a question. It might be answered by any of the speakers. Now, you know that diabetes as a problem, how much these technologies or new treatments can be used or can help reduce the burden of diabetes globally, because as you know that diabetes, 2/3 patients with diabetes, and I'm talking here about type 1 diabetes, they live in poor socioeconomic countries. So do you think that can help there, or should we look for maybe some other means to control diabetes in such low economic countries? So Nasir. Dr. Nasir with us?
Dr. Khalid, you can repeat the question again, please?
Yeah, I was saying it was a question for everybody, anybody who can say, you know, the diabetes is a global problem, and 2/3 of the people with diabetes live in low socioeconomic countries. Now, do you think that these new medications can help in there? Because I've been discussing this with some colleagues in Pakistan, Egypt, and other countries. They really find difficulties to use this new insulin analogs and the new, let's say, class of GLP-1s and so on, insulin pumps.
You are right. And with the same price, will not be affordable in low-income or middle-income countries. This medication, they are new, they are very expensive, so maybe not affordable. For I know it is beneficial. All the technology, they are beneficial. All the new medication like GLP-1 and selective glucose transporter show improvement in admission for heart failure, cardiovascular disease. Okay. But of course, there is a big problem regarding the affordability in the low-income countries. So will not be applied there. They will accept the regular or usual treatments like regular insulin and BH.
Mm-hmm. And do you think that we are, as physicians, pushed by the drug companies to use a more expensive sort of medications? For instance, if you got a patient who is controlled on Lantus, you have to go for other long-acting insulin like Toujeo or concentrated insulin. So I feel myself that drug companies are pushing physicians to use more expensive sort of medication. So what do you think about this?
Many patients, they can be controlled in conventional therapy, not in new drugs actually. There is specific indication. And for example, a new insulin analog to J or Digladical, use it if the patient has recurrent hypoglycemia, nocturnal hypoglycemia. But you know, when it is available, like Ministry of Health, will be used for, because we use it freely. So it will be available for all the patients. But of course, if we have limited resources, of course, should be compelling indication to use it.
Thank you very much. Dr. Badi, what is your experience with patient on pumps?
Yeah. Thank you, Dr. Khalid. Dr. Khalid, I think the main line of management of type 1 diabetes in children, still it is the education. The family is educated about the diet and importance of exercise and the importance of following up the patient, the doctor, and doing the investigation. So this is the main line of management. Actually, the technology, it is okay, it's important to improve the diabetic control, but however, the absence of technology did not mean poor control.
Yes.
أنا في قصة دكتور خالد أنا تذكرتها الآن أنت تتكلم دكتور ناصر.
Yes.
I have one patient, الأب طبعا راعي غنم يعني في الصحراء وما عنده أي إمكانيات لقياس السكر وأنسولين بامب ما في غير الأنسولين بس. لكن الأهل educated يعني بالنسبة للأنسولين ثيرابي وبالنسبة للدايت بشكل جيد بحيث أن الهيموغلوبين A1C ما يتعدى 6.5 أو 7. فبالنهاية تعتمد على المريض. Yes, the diabetes technology improve the life of the patient, but it is not necessarily for the diet control.
Actually, this is the message maybe that we want to achieve. That it's not a must that we run after the new medication. If all patients are controlled, I don't think there is a need. So, except of course, as Dr. Nasser said, if a patient got repeated hypoglycemias or there is special need to go for this drug. Yes. Dr. Bandar, any comments from you?
Agree totally for the comments from my colleague, but maybe I like to listen from Dr. Badi and his experience, and of course Dr. Khalid and Dr. Nasser. I have many patients who were interested to have an insulin pump, and once insulin pump is around and they are connected to insulin pump, unfortunately A1C is maybe sometimes not even the same, maybe sometimes is higher. They are not motivated, they have a poor control in blood glucose. Is it our fault? Is it patient fault? We know that this insulin pump is a high technology device and it should give us a better control. But unfortunately, our patients, they are not, I cannot say 100% of them, but we have plenty of patients, they have a poor control. Can you comment on that, please?
Dr. Badi.
I think, Dr. Damanhouri, the selection of the patient for the pump. If we don't select the proper patient that they are motivated and the family, they are motivated to do frequent glucose monitoring and they do carbohydrate counting, okay, it will fail really. Because like somebody, I give him a mobile iPhone 13 and he cannot operate Abu Kashaf. This is the problem. And we give them advanced technology for them and they are not doing the minimum requirement for glucose monitoring and boluses and adjusting the bolus and ممكن يعني فهذه very important in education. The other thing, as we know, the pump is not appropriate for all the patients. Maybe they are patient, they are not comfortable with the pump. The other thing, pump will not control 100% of the patient. Like if you go international for glycemic control, يعني 50 to 30% they are controlled. Saudi Arabia 1/3. So 70% will not be controlled even in the best centers really. So it's not easy to control hemoglobin A1C. But I mean selection, because here the patient, they are not selected, they are not arrested, they are not motivated to do glucose monitoring, carbohydrate counting, nothing, not following the diet, nothing for bolus for snacks. So I think there is a lot of issues.
I agree with Dr. Nasser regarding the insulin pump. Our experience in our center, we send the patient to the diabetic educator and dietitian for carb count. And we make sure that the patient have glucose checking for 10 times daily. And the family is educated and eager for the technology. After that, most of the patients who receive the insulin pump, they have good results. However, we find that the patient who get the insulin pump from private hospital, some patients, they think that the pump, it will do all the job. So he will just put the pump and it will control the blood sugar. And it's not correct. So it depends on the patient at the end.
Yes, I got a comment here from one of our diabetes educators in Noor Hospital, Noura and Nadawi, and she's saying that although despite all these updates and all in the technologies and in the medications, but she still thinks that there is a huge gap in clinical practice. And I would definitely agree with her. There was a time where the Ministry of Health distributed or gave every and each patient with diabetes a glucometer and strips and so on. And despite this, we did not notice any improvement in the A1C of patients. That was 3-4 years back. Anyway, let's bring us to what we said in the beginning, that we are still looking in diabetes as a retrospective management, and we should go more for a proactive. I think this is one of the ways that can really help diabetes management in clinical practice. So I don't have any other question. You allow me now. We should go for a session that we need to hear from all our guest speakers. The title for the IDF for this World Diabetes Day 2021 is Access to Care. Diabetes. Now, how do you feel this in our country, in Saudi Arabia? We don't want to talk about other places, but do you think that people in Saudi Arabia, in different cities, have good access to care? They can get the care they need, as we said, at the right time, at the right place, and by the right team. Is this, how far are we good in this area? If you want to comment, and the floor is open for to hear your comments and ideas.
Khalid, if you allow for me. In my personal opinion, for Saudi, I'm not talking about non-Saudi or not eligible, of course. Okay, but in general, Saudi Arabia.
Yes, Saudi citizens.
There is good access of the care if you compare with low income and middle income. But the problem, the care is fragmented. Patient come to hospital, no hospital, then go to Hura, then come to Jeddah. So really a lot of information, there is a fragmented care, no unified care, no unified file for the patient, okay? The other thing, we don't have modules for diabetic patients. Ideally should be, there is a module for them. How frequently you do, for example, urine microalbuminuria, fundus exam, foot exam, all this need module to remind the physician when should do it, okay? I know there is personal sometimes, but the standard, at least up to the standard. So the care is there, but fragmented. The other thing, there is no unified electronic file. I cannot access the patient seen in a Noor hospital or in the Yamama hospital. They are the same also. They cannot access our patient. They can access the radiology. The other thing, there is no qualified people. There is deficiency in the number of diabetic educators. We need a lot of education. We need a lot of educators. This is more important than the technology, actually. So there is still shortage of a qualified physician dealing with diabetes, especially with insulin and type 1 diabetes. And also there is there is shortage in clinical dietitian and educator in a primary healthcare center that they see almost 70% of the patients. So really still there is a lot need to be done.
How often do you see your patients, Dr. Nas, in your clinic? How often do you see? Per year, how many times?
Depends on the situation. And now we'll avoid a special situation like a pregnancy or not. So usually 3 to 6 months.
3 to 6 months.
Yeah, and usually if controlled 8 or above, 6 months. Sometimes occasionally 1 year we give.
Yeah, and I think in Al Noor Hospital, I know it's about 6 months to see patients. So patients are seen twice. Is this good enough? I mean, I know that the patient also can go be followed in the primary health care, but do you think there is a sort of continuity of care between the diabetes center and the primary health care? Can the patients get the same care as needed? For instance, regarding fundus examination, food examination, looking and treating other complications, identifying the complications early. I mean, is the current system, of course, is a lot better than before, because I lived the area where there was no diabetes centers, and patients were seen in different clinics. Now we are much better now, of course, after the presence of. But I want to hear, are you satisfied? I mean, as a physician, are you satisfied? Or do you think you can really improve the care? It's an open discussion.
Yes, if you allow me.
Yes, sure.
Yes. In diabetes center level, I can say the issue is okay, or the management, I'm satisfied. But unfortunately, in primary healthcare level, I feel that still we have a lot of work and a lot of improvement to be done. Many patients refer to us in diabetes center to be controlled with high A1C, and this is the idea, definitely. Once patient in control, we know that he should be back, or she should be back to primary health care to allow new patients to come. With A1C of 6.5, most of our patients, they are not accepting to go back to primary health care. And you will go for this dilemma. He will not be accepted, or he is not accepting. Even if you refer him, they said that maybe they have no, for example, simple investigations, no fixed consultant to be followed at the family physician level, etc. So most of our patients will be with us. We will be more stuck, and we have many patients to be followed in diabetes centers, and they are not candidate to be followed here. And unfortunately, no new slots for the high A1C or uncontrolled diabetic patient. So I think the work or the improvement should be done, or to have a more work in primary health care level to satisfy, or to have more satisfied work or modified, unified work.
Also, Dr. Khalid, if you allow me.
Sure.
I notice in children, we are following them up to 14 years. And at 14, we refer them to adult endocrine. So I noticed some of those patients, they are well controlled with us. And then when we refer them to adult endocrine, some of the hospitals, they will not accept them. So they will go to the primary center and they will have poor control diabetes. So they will come after 1 year, 2 years, just to take the medication or to take the sensor. And we will find that hemoglobin is 13, 14, because they are following in the wrong place, I think. I think diabetes type 1, they have to follow with pediatric endocrinologist, then adult endocrinologist, not with the primary. My opinion regarding type 1 diabetes.
You cannot see them after 14. Maybe in some areas, I think they pediatricians are seeing them maybe up to the 18th.
We are following them according to the MOH regulation up to 14.
Up to 14. And then you send them to diabetes centers.
Yeah, diabetes center, but sometimes they will not be accepted. So they will go to the primary center that is near their home. And, the care will be, not will be optimum like the diabetes center. So they will have a difficult time there.
And how much do you think, all of you, that the artificial intelligence or the use of telecommunication can help in reducing this problem, allowing us to monitor our patients more, to talk to them more, to have a consultation more often with them rather than 6 months. You can talk to them anytime. How much do you think is the need for such a sort of change in way of management of patient with diabetes, our current way of look at the patient? How much do you think that we need this sort of?
If you allow me,
yes.
I think it will be helpful for the patient. However, for a busy clinic and a busy physician, it will not be an easy thing to be done. As you know, our clinic is full of patients. So now we are going to move to the virtual clinic and more patients virtually. So I think it will be helpful from the patient, but as a physician, it will be more difficult.
I see. Because I mean, staffing is the problem.
Yes, I get it.
Staffing is the problem. Dr. Bandar, Dr. Nasser, any other comments?
I think, Dr. Khalid, no virtual clinic, the plan of MOH to go to virtual clinic actually.
Mm-hmm.
And I think in their plan, they will increase the number of clinics. We know that an average consultant usually 2 clinics, not like a private. Private, we have 10 clinics. So yes, this is in the plan actually, because there is no تحول for private, for insurance. So want to make sure there is increased productivity. Now they collect all the productivity of the consultant. So really it is going by default for virtual clinic. This is the plan actually.
Yes, I think this is the future. I think telemedicine.
It's starting.
Yes, I think it will be very, very helpful. And it is more economic, by the way. Instead of asking the patient to come to the hospital and seek an appointment which could not be available, it's more economic and give us more.
It faces a lot of problem.
More contact. Yes.
the patient, they don't know how to use it. This is when the other technical support, need internet, need camera, need need some setting before you do it. It's a simple setting, but
that's right. That's right. But patients can use their mobiles. They can use their mobile. I think most of the patients now have mobiles. But if, of course, it's something new, and I think we need it more and more. Have more and more patients, because we will come to the area where we see our patients every year once. Now we see them twice a year, unless we do get benefit of artificial intelligence. I think by time we will maybe see our patients every year, only once a year. I think this is one of the solutions. And as I said before, we are going to have a training on the use of these artificial intelligence next week. So anybody who's interested, please contact me. We will give you live documentation how can this be used management of.
excellent. هذه كيف حتعطينا إياها؟
والله I will set a time inshallah next week, and you can attend and see. It will be a virtual meeting, and we already have the glucometer, and we will show you the applications, how to use the application both by the physician and by the patient, and how to interpret the data and so on. Inshallah, next week we will have a training. Not yet decided, but definitely inshallah next week. Could be Monday, Tuesday, something like this. And I will try to do it in the evening time so that you are free. I already invited have someone diabetes center in Noor and Hira attend. Anybody can attend.
And make recording of it if possible.
Sure. We will do that, definitely.
Yes, Dr. Khalid, I'd like to finalize by something related to health educators dealing with diabetic patients. As we know, in the era of COVID-19, the health educators and of course other health professionals facing a challenge about social media infodemics and their impact on the mental health and psychological health of their patient, including, of course, diabetic patients. Infodemic means excessive amounts of misinformation that make it hard for people or patients to find reliable sources and the guidance when they need it. Because of the lockdown, many people stayed at home, so spending more time on social media looking for news and data about the pandemic. And here in Saudi Arabia, the Saudi Ministry of Health launched a positive initiative to relieve the psychological burden and mental stress among the healthcare worker facing the epidemic. But I think we need similar intervention targeting susceptible patients of chronic disease, particularly diabetic patients. Hence, the important role of a health educator to stress on their patient on acquiring information from reliable sources. Otherwise, the condition may be complicated by psychological and mental burden that sure will affect the diabetic condition in general. That is.
Yes, of course. Again, artificial intelligence can in patients and family education. And you can do this with very ease, your convenience, anytime. You don't have to working hours of the hospital and use it 70 24 hours, 7 days a week. Any other comments of the speakers, or we conclude? Okay, thank you very much. I got one comment here that saying patient education is main player, followed by follow-up, his or her attitude and behavior to get treatment. Very nice comment. I think behavior is something else. Behavior is something else. Education is something, and behavior is something else. I think we need a lot to talk about behavioral change. But anyway, it's a very nice comment. At the end of this symposium, I would like to thank all the speakers. Thank you very much. We have taken you from your vacation day, Saturday. We very much appreciate your participation. You have definitely gave us a very excellent updated information and data, and I'm sure those who joined us today, they did benefit from the information that you gave through your lectures. I hope that you will be members of what we call the Education and Diabetes or Education and Training Center in Shifa, and we definitely need your assistance and cooperation all the time. Thank all those who attended the symposium. I'm sure that, as I said at the beginning, I'm sure we will have a lot of failures, as this is our first symposium to arrange through our diabetes, education center. So I would ask you, please, if you have any comments, be sure that we are going to listen to you. Just write to us your comments, ideas, and we will try to improve our inshallah, our level of care for these symposiums. We will have, inshallah, 2 or 3 symposiums already our line in December and January. So please be with us. Thank you very much. Assalamu alaikum wa rahmatullahi.